Recording, right? Right, well, I think we're about ready to kick this course off. Good morning. Welcome. You guys feel like you've already been through like half the material now with your first 6 chapters and the ones at the end of the book? So as you can tell, there's a lot of material we have to cover in this course in a very, 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 very condensed time. So we'll do our best to make the course as interesting as we can. Unfortunately, anything within that book is liable to be on a national registry exam. And since we don't make that test or have any control of it, you guys are 100%, in charge of your own education here. We will do our best to present the information, but we are not presenting every single line and every single page of that book. You guys have to read your chapters if you want to, pass the exam with flying colors on the first try. So anyway, not to scare you, but we will do our best with what we're going to present. But this is just as much on you guys as it is on us to get through the class, but it'll be fun. Before we actually get started into the material, though, let Pete talk to at least to the people that are here just kind of about this facility, since it's new to most of us.
So those of you who don't know who I am, I'm Pete Hawley from KCFR. I'll try to be here, planning on being here for every class. So if you have any questions about the facility or anything about access, hopefully I'm not a great IT guy, but I'm trying to get dialed in on this stuff. So hopefully we'll be up and running. But if you have any questions, let me know. We should have coffee going every time you're here. If the coffee pot's getting low, just let us know. We can brew another pot. Bathrooms are out through the hallway. Trying to think of anything else that we might need to discuss.
They need Wi-Fi.
Oh, yeah. I don't know. We can get the Wi-Fi. I'm not even sure what the Wi-Fi is.
Fire safe, but I think we have one specific. I'll try to find out. And
yeah, we'll find out and get you
up somewhere so we don't have to say it every month.
Yeah, that's good. Any questions off the bat on that?
Okay.
Perfect.
So the classes and the skills weekends will all be at the same spot. So we're still working on making sure we get enough equipment here for all the skills days and stuff, but it will be here. As well as the Psychomotor Exam for the National Registry at the end. I actually just got a call from Heather Griffin at Idaho EMS this morning while I was driving here to the class, and the April 13th, that Saturday date that I sent out, is now confirmed. So that will be the Psychomotor Exam. If you can't take it that day, you don't have to, but that's going to be the only one we offer here locally. So it'll be up to you then. You're going to have to find another one elsewhere.
You know what time?
I don't know the time. We'll try to schedule it first thing in the morning, but I don't have a specific time. And plan on it taking most of or all the day, the whole day. April 13th, is that a Saturday?
Yes.
Okay, yeah, April 13th. And we are opening that up to outside students. Heather had no idea if we would get any or not, but it will be opened outside. And we've also agreed to piggyback a psychomotor paramedic exam with that same test. She, again, doesn't know if we're going to have any paramedic students, but she'll keep us informed. So it won't be, or it possibly won't be just our classes here for that test date. Okay. For those of you that are here, I have packets on the back table. It is a huge packet of information all about your clinicals at Kootenai Health. For those of you guys that are off-site, I'm going to have to get these packets to you as well because they're not just information packets. Almost every single page in this packet requires your signature and a date. Okay, I have to get these packets filled out from all of you and submitted to Kootenai Health for you guys to get badged to get into the hospital to do your clinicals. If you are an I-85 already and have elected not to do the clinical health clinicals, you do not have to worry about this. Some of the I-85s do not feel like they need to go in and do their IVs because they've already been doing it. I'm fine with that. Everybody else, I need this packet filled out. And if I have any students lagging in this, it's going to hold up the entire class because per Kootenai Health, I can't give these to them individually. I have to submit our entire class with one big file all at once. So it's very, 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 very important that I get these. So ideally, if you guys could fill these out and get them to me either today or by next class, I would appreciate it. For you guys that are off-site, I can send you the online way to get to this form filled out. You can fill it out and send it to me. You'll have to scan it in and send it to me. Or I'll get Chief Isaacson a handful of them, and I'll have a handful of them, and we'll try to get them to you guys. But these have to be done soon. Now, there's a whole bunch of information that this packet refers to, which are the requirements for Kootenai Health and information that they have. I did not print these for all of you. I will send you the link to all of this, because this packet is the information packet for all of you that you don't have to fill out, that you just need to read and be aware of. This getting you guys into Kootenai, I'll be honest with you, it's been a nightmare. I started working on this in November. I still don't have it confirmed yet. We're still trying to jump through all the hoops that the hospital requires now. It's not like the old days when I'd call up the ER and say, hey man, we have a couple of students, do you mind they come in? Sure, have them come in whenever dates they want. It's a huge process now. But I will send you the link to the Kootenai Health packet, but these smaller but still large packets with all the signature lines, I need these soon. Questions on those? Okay, as far as the requirements to get into the hospital, besides that, I know I sent you guys an email. The CPR card and or roster, I have to have that. I have to either have a copy of your card or a roster of where you did it in-house in your department. So if you have department-wide ones, that's fine. All the Coeur d'Alene people for the CPR, I've got that part already. I have to have a date when you had your flu shot. I don't have to have any documentation that you got it, just a date you had it, as well as I have to have a date when you had your last TB test. They're not asking for results of those unless they can ask for them, but they're not now. They're just wanting dates. So I have to have those 2 dates. If I don't have those, you cannot go and do your clinicals. They won't let you in the hospital. The other thing that you have to have to get in the hospital, they typically require drug testing. Since you guys have random drug tests through your work, they are waiving that for us. They also usually typically require a complete background check. Thank goodness, since you have to have those for licensure to become an EMT, they're waiving that for us as well. So you don't have to worry about those. And so I think that's all I need at this point. The other thing I have to have for your clinicals, and I'm talking about this up front because this is really time sensitive. Kootenai Health wanted this information all to them about a month ago to get you in by March. That's how long it takes them to get them through this. I told them I couldn't get that all because class wasn't going to be started yet. So we need to get all this done soon. For those of you that are here today, please do not leave without me getting your picture taken. I have to get pictures taken of everybody for your Kootenai Health badge that they're going to give you. Because you have to have a Kootenai Health badge, you cannot do clinicals. And for those of you that are not here, either you need to send me a picture or I will have to come take it at some point. But the details on that, it has to be a dark background, and it has to be the top of your shoulders and your head. It has to be, that's all they want, top of your shoulders and your head with a dark background. So I'll do that today with those of you that are here. If you're not here, please try to get me a picture. You can just take it with a cell phone as long as it's a dark background, shoulders and head, and get that to me. Because again, I have to submit those to the Kootenai Health all with one big batch. We can't have you guys individually submitting them to Kootenai Health. All right, questions on the clinical stuff. There are sign-up sheets in the back of the room for the 2 clinical dates you're going to have. I was hoping to get you guys all in for 3 days, but due to the restricted time we have to get you in class and the Kootenai Health only allowing 1 student in department per day, I can only get you guys in twice. You're going to get 1 in the ER. And in the ER, you can do IVs with them there or just help out with whatever else they may need. And then you're going to get another day in specialty procedures, which is where they go in and do like scopes and stuff, which people get sedated, but there's not sedated as much as they are in the OR, but they still all have to have an IV so they can get sedation meds. So you'll do a day there. Now, specialty procedures allowed us to get students in Monday, Wednesday, Thursday, and Friday, but only 1 per day. And I don't remember the specific times on that, but it's going to be like around 7 in the morning until 2 in the afternoon, I think, for that one. If we can't get everybody in those days, pre-op for the operating room has also said they would take some students. They would not take the entire class. And so it's going to kind of be a backfill in case we can't get you into specialty procedures. We'll get you into the pre-op. Those are going to be super early mornings. They typically want students there ready to go, starting to do IVs 5:30 to 6. So we'll see. But I only put the sign-ups for the ER and specialty procedures back there, because I'm not going to even send anybody to pre-op unless we have to. It's one person per day on the sign-up, first come, first serve. For those of you that are off-site, you're kind of going to be behind the ball from the guys in class today a little bit, but I will send you all the open dates at the end of this class that we still have. Questions on that part? Yeah.
We do thank you, Echo, the guest Wi-Fi if you want for your phones, because cellular reception here is iffy at best. It's KCFR guest, and then the word fire safe lowercase.
Okay. If anybody's off-site, if you don't mind, I made this announcement a little bit ago, but more of you guys might have joined in. In the chat part of GoToMeeting, will you please put, if it's just you, we can see who you are. But if there's anybody else viewing with you, please put their names down, whether they're students or not, because if they're students, we need to know they're viewing. If they're not students, I want to be able to give them hours for CEs. So if you guys don't mind putting that in the chat box. Okay, and some other information I have available to you guys here at the class, and you guys can also get this online if you're curious. I did print out the scope of practice, because there's been a lot of questions on, all right, what's the difference between an I-85 and the new Advanced EMT? What can I do? What can I not do? So I do have a copy of the state scope of practice, which, again, is not necessarily everything you're going to be able to do here in Kootenai County. Currently, as it stands today, once you guys get through this class, you're really only adding in IV therapy to your skills. It used to be IV therapy and the supraglottic airways, but the eye gels are going down to the basic level, so at this point you're only adding in IVs. But that doesn't mean there's not an opportunity for that to change. When we get closer to the end of this class, or to the end of this class, I think it's going to be time to reapproach this with our medical directors, find out where they're sitting on this, and it may change in the future. And hopefully it does. But I'll just have this in the back of the room at break time if you are curious the difference between the I-85 and the Advanced EMT scope of practice within the state. That's also available on the Idaho EMS website. Okay. So at the end of the class, following our class, there's 2 tests you're going to have to take. You have to take the written exam for the National Registry as well as a psychomotor exam. I talked about the psychomotor exam being April 13th. What you will be tested on April 13th. There are going to be 9 skill stations you have to go through. And you can write these all down if you want, or if you go onto the National Registry site, they're all listed right there with all, you can print out the skill sheets and it's all there for you. I did not print skill sheets out for everybody because it's easily accessible through their website. But you're going to have to do a patient assessment trauma, the patient assessment medical, ventilatory management, so the supraglottic airway device, a pediatric respiratory compromise, cardiac arrest with AED, IV and medication skills. Now, that's broken up into 2 different sheets. They're actually 2 different tests, but you'll do them back to back. You'll go in there and do one, and then you'll do the other in one station, even though there's 2 separate things. The IV and then the medication are 2 separate skill sheets. Pediatric IO, spinal immobilization of a supine patient, and then 1 random skill. Now, the randoms could be the seated spinal immobilization, long bone immobilization, joint immobilization, or bleeding control and shock. And those ones come right out of the basic curriculum. It's the same skill sheets. But those will be what you have to get tested on, so we will make sure that we cover all of these at some point during the class. As you see on your schedules, you'll see days where we're doing introduction to skills. That does not necessarily mean that that day you're going to have a chance to practice all of those skills, because usually those coincide with lecture time. No idea how much time we're going to have for all of those. So it might be we do a lecture and the instructor just, plays a video demonstrating the skill or demonstrates the skill live to you guys. It's going to be really up to you guys to find somebody at your stations to help practice all these skills. Now, we will have open skill time on the weekend dates that we meet. And please, 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 please try to be at those dates. If you're on duty, it would behoove you to try to get a trade or coverage or something during those times. because that's when you're going to get most of your hands-on time. If you can't make it, you can't make it. In that case, you're going to have to make sure you find somebody to help you practice these skill sheets on your own. So make sure if you're having like somebody at one of the stations help you with IVs, they can teach you all their personal techniques they do and how they do it and what works for them. That's great. But make sure you practice the National Registry sheet, because that's what you're going to be graded on step by step by step by step when you test. So it's good to learn the what works great in real life, but you have to know the testing sheets. Questions?
Is there anything we need to document hours-wise if that's the case?
Nope. Idaho no longer requires specific hours. They don't require a specific number of sticks. They don't require any of that. It's all competency-based now. Basically, at the end of this class, I have to sign a form saying I feel you guys are all competent to take the test. It doesn't say I'm confident you're all going to pass the test. It's I'm confident that you're all able to take the test. And it's just basically me telling the state, yeah, they attended the class, I feel they're ready. But they took out all the real specifics. All right, any other questions on that? All right, so today we'll kick off with Chapter 7. Oh, there's one other thing I want to talk about before I get into this lecture. It has to do with the tests and the quizzes with this class. So on the JB Learning site, I know most of you, I don't know if all of you have, but I think you have completed some or most of or all of the chapter tests that were assigned for you. There are two things on that site. There's the quizzes, and then it says chapter test. The quizzes are optional. I recommend it because you're going to get a better idea of where you're at. The tests are not. The tests are where you're actually being graded on. Okay. Now, what we set up for this class is a 70% minimum for a cumulative score of all your chapter tests, and then you also have to get a 70% on the final in order for me to sign that sheet saying you're ready to test. I have specifically not given those test questions to the other instructors. Some of them have asked me, and I've said no, and there's a reason for that. I do not want us teaching to those tests. And I'll be honest with you, I am randomly picking the questions as well. I'm not even going through and reading every single question. So I know I've heard from a handful of students some of the questions are awful. Okay? That's okay. I mean, it just is what it is. I'm not worried about you guys not getting that 70%. I think you'll do fine. So if there's some really bad questions that you don't make it through, we'll live with that. It's okay. But I don't want to teach to those tests because I don't want to give you guys a false sense of security with how you're really doing and how you're managing the material. Because if I'm specifically teaching you to 10 questions or 20 questions, and there's a whole bunch of material that we didn't cover very well, you guys might think, oh man, I'm doing great because I know all 10 of these questions. Well, maybe not when you sit down for a National Registry exam. So that's why I want it completely random. And just like the national test, some of the questions are awful. They suck. And some are really good. And you just got to have to, weave your way through it all. But I just don't want to teach to a test to give you guys a false sense of security. I want you to really know or really feel where you're at. I did make one change with the test starting today, though. At the end of every single lecture, and I already have these built for the whole class, but at the end of lecture, so at noon today, your Chapter 7 exam will open and you can take it. Okay? And you'll have till the end of the course to finish it. I gave you guys all to the end of the course to do all your exams. I would recommend you don't wait till the end to do them all. Do them as soon as you can. But at noon, after every chapter is finished, that chapter test will be open. You can't take them ahead of time, but at noon when that chapter is completed, the test is open. I did change it though where you can take the test 3 times. So you get 3 opportunities. Your highest score is the one that counts. Even though they are random questions, I did go through and I didn't read them all, but I specifically selected the questions I'm putting on the test. So I think when you retake it, it should be the exact same questions because I didn't give it more questions. I just gave it and from now on, I think they're all 20 questions. I gave it the 20 questions to put on the test. So it should be the same questions. Probably a different order. Don't know. Maybe it's the exact same order. But again, you guys can take these tests on your own. There's not going to be class time for these tests. The only one that there's class time for is the final exam. Everything else is completely on your own. So is it open book? Technically, yes. Is it timed? No, you can take as long as you want to do it. But again, if you're looking up every answer in your book and answering it, you're going to give yourself a false sense of security, because you might get 100% on every exam, but you don't really know it. The book knows it, and you're just finding the answers. So please, for your benefit, don't use these as open book tests. If you've done it twice and you're miserably failed each one, well, maybe the third time you should open your book. But then you need to know you got to study. Okay? Questions on the tests?
If we flag the question, does that mark it? Because like there was a few times in the first 6 chapters that it contradicted itself.
Yeah, I've heard that too. It marks it. I mean, it does flag it. We can go in and see that it was flagged, but it doesn't do anything more than that.
Okay, I just was curious.
Yeah, and I've gone through and looked at some of them that people complain about, and I agree. I mean, there are contradictions, or there's some of them that I think the answers aren't the best answer, but yeah, it's typical testing.
Scott, did you see the question from Eric?
No.
About how do they access the recorded class?
That is something we're going to have to figure out on the fly here, because at least for today's lecture, once we get done with it, we're going to upload the content, I think, onto a thumb drive. And that'll take a good hour at least at the end of the class. How I get that information from the thumb drive out to people is what we're still trying to figure out. I'm hopefully going to be able to do it through some cloud-based thing where I can upload it into the cloud and you guys can all access it that way. But that is going to have to be something I'm going to have to tackle the next couple of days to make sure. So I don't have an answer for you, Eric, or anybody else. They will be recorded. How you access the recording is still questionable. All right. So Chapter 7, the human body. I'm going to apologize a little bit in advance for this lecture because there's no way we can cover all this content in depth. I mean, as you guys know who read the book, we are covering the entire human body from cellular structure through every major organ in one 3-hour lecture. I mean, almost every single area of this entire lecture could be a whole semester class if you wanted to get really, really deep into it. But as you see from their book, there's lots and lots and lots and lots of detailed information that you guys are responsible for. Typically with National Registry exams, they do not get super deep into the nitty-gritty stuff. Like, I mean, they're not going to ask you all the components of the inside of a cell. Okay, they typically don't get into that kind of stuff, but they get into the more big picture understanding stuff. So you're going to have to know how the cells work, how they form tissues, how the tissues work into organ systems, and all that works together to answer some of the questions that they're going to ask you. Now, could they ask you any random name of a structure and what it does? They could, but typically it's more, if you find a patient that's presenting like this, what could it be, or what do you need to do, or what is this, might ask about like big things like chambers of the heart. So I would not, if you're having a hard time keeping up with everything, do not spend most of your time memorizing the little teeny tiny anatomy and physiology names for everything. But you have to understand how they work, okay, and what the cells, like for cells, what the cells does. All right, let me get this one caught up with this guy. For those of you guys that are off-site, if I don't advance the lectures, or you guys here too, let me know. All right, why isn't it working? Let's go off. Okay, so first of all, today again, we're talking about anatomy of the human body. Pathophysiology is going to get covered later. And each individual chapter, when we get into like cardiac or we get into respiratory, it's going to also kind of briefly cover the anatomy again. So you're going to get all of this a few times. In the chapters, like when we talk about the cardiac anatomy in this chapter, you're going to get it again with cardiac, but more in depth. So today's just going to be some of it will get kind of deep into stuff, but it's going to be overall a brief entry into each body area. But when we talk about anatomy, we have gross anatomy and microscopic anatomy. And it's that simple. Gross is what you can see with your eyes. Microscopic is what you need a microscope to see. And it doesn't mean that you can see it without cutting open the body when we're talking about gross anatomy. It's just like if you were to slice open the body and look at the heart, can you see the heart with your eyes? Yes. So that would be gross anatomy. If you need a microscope to see it, it's microscopic anatomy. What is the difference between anatomy and physiology? Because there are very two specific things you talk about. A lot of times they're taught together, but they're very specific.
Physiology is how they function.
Yep. So anatomy is what the structure is, the components of it, what it's made out of. Physiology is how it works and how it works with other organs or other, how it all works together. So one is just what it is and one is how it works. Okay, cells. Cells are the basic element or structure of what our bodies are made out of. Is it important to know what's in a cell? Sort of. Do you have to know every little intricate part of what's in a cell for our level of medicine? No. But there's a few things that we need to understand and know how they work and know that there's different cells for different things. But there's basically two different classes of cells. Sex cells and somatic cells. Sex cells are just what they are. They're the cells used for reproduction. They have their own classification all by themselves. And somatic cells are every other cell in your entire body. Why they separated it just that way is beyond me, because they're basically talking about a couple different cells versus lots and lots and lots and lots of cells in the body. But that is how they separated it out. Okay. Now, a stem cell, what is the difference between a stem cell and some other type of cell? Do you guys know the difference there? Right, it's a cell, but it can basically become or do anything it needs to. So it can reproduce cells, other cells, that then become specialized themselves, but the stem cell itself is not specialized. Where all of the other cells, even though they start with basic units, they become very specialized for whatever they're going to do. So if you are a muscle cell, that cell changes to have the components and capabilities it needs to do to make the muscles work. If you're a cardiac cell, it's going to be different. If you're a skeletal cell, it'll be different. Neural cells are different. They all have very distinct roles, even though the basic components of them are fairly similar. Every cell, though, in itself is a living being, and it has a respiratory system, basically, and a secretion system, because it has to be able to get oxygen, it has to be able to get glucose and stuff in and out of the cell to function. Okay? So when we talk about the body needing oxygen and glucose, it's not really the body itself that needs it. It's these cells that need it. So these are the important things that, live and keep us functioning. They do communicate with one another and the body through electrical, chemical components that is way beyond what we need to get into here. All right, at least when I teach, guys, when we have a picture up on the board that just is showing all the components, I'm not going to sit here and go over the picture with you and point everything out. You guys have the book. You have the pictures right in front of you. If it's just purely memorizing and putting stuff together, you guys don't need me to sit here and just read pictures to you. Okay, cells do have a membrane. They're bilipid membranes. So basically what that is meaning, like you can see in this picture, it's got the little ball with the little feet off of it, and the little feet go inside on each one of them. Each one of those is a lipid, and it's a bilipid layer, meaning there's two different layers of those lipid layers. Now, stuff can get through the cell wall and needs to, but they are also only allow certain things in and out of the cell, and not every cell is different. It depends specifically what that cell does and what chemical reactions need to take place, what it allows through that bilipid layer through different channels. So you do not need to know the specifics of what goes into what cell and what goes out of what cell and how that works. Just know that the cells do allow things in and out of the cell continually, depending on the cell, to function. Some of it's just fluid. Other times it's different elements. It could be glucose, it could be sodium, it could be lots of different things that go in and out of the cell. But just know that things continually are moving in and out of those cells. Okay, so cytoplasm is part of the cell structure itself. It's the fluid material within the cell. Now, initially, when they started looking at cells through microscopes, and the microscopes weren't near as good, they could see that the cytoplasm was fluid and it just had these little specks in it. They didn't really know what the specks were. Now that we have much more sophisticated ability to look at these small structures, they actually find out that there's lots of stuff within that fluid of the cell. And actually within that fluid is where most of the work of the cell happens. Even though there's a lot of big structures in the cell too, big is at a microscopic level, but bigger structures within the cell, most of the inner workings of what that cell does is within that fluid. And the crystal is the fluid portion of the cytoplasm, and there's water in there, glucose, amino acids, lipids, proteins, ATP, and waste. So all of that is within that fluid part of the cell. And so you can see with all of that, there's a lot of stuff that happens in there. I don't know that you guys need to know that super in-depthly, but just know that even though there's lots of bigger components of the cells, like the nucleus and mitochondria and stuff, even the non-structural stuff, the fluid part of the cell, has lots of stuff that happens within that fluid. All right, and there's lots of organelles within a cell, so these are the bigger structures within the cell that do lots of different things. And here are some of the organelles: the centrioles, cilia, and flagella, ribosomes, the ER, or the endoplasmic reticulum, and there'll be some on the next slide as well. I'm going to go over, what some of these do. Again, I really don't know how in-depth you guys really need to know this. I don't think it's going to be stuff that they're going to focus on a national registry test, but a chapter test may have some of this stuff. So the centrioles, they aid in cell division and the movement of DNA. So when a cell is going to divide, depending on what type of cell it is and how it's dividing, the centrioles aid in that process. So if it's going to be a cell that divides and the DNA is going to separate, so you're going to get half the DNA in one cell and half the DNA in another cell, this will help divide that DNA and sort it. What kind of cell would you split your DNA? It'd be more with the sex cell with reproduction, right? Because you're going to get half that DNA from you and half the DNA coming in from your partner, and then those DNA strands are going to join back up. Other cells in the body, though, where they're just reproducing, which are really obviously most of the cells in our body, they're reproducing themselves and creating other cells that are just like them. They don't have to split that DNA because the DNA is the same. And so they make basically exact copies of themselves without splitting that DNA. Okay, the cilia and flagella, what are these guys for? In one word, movement. All they do is aid with movement. The cilia are little hair-like structures on the outside of some cells. Not all the cells have them, but some cells. And they aid in moving fluid past the cell. It's more that they say that a cell actually tries to push the fluid past it more than it's trying to move through the fluid. It's just trying to push fluid beyond it so it can exchange nutrients and stuff with other parts of the fluid around it. The flagella is a propel mechanism, basically what pushes the cell forward, and there's really only one basic type of cell. There might be more, but one that they really refer to that has that function. What is that? The sperm cell. It has to be able to propel itself in through the liquid to be able to get to where it needs to go. So it has a propulsion system. All right, the important thing with the ribosomes is all we need to talk about that is they form proteins. Okay, so within the cell, that's what helps form the proteins within the cell. The endoplasmic reticulum are simply pathways. Just think of them as pathways within the cell. So that is how different proteins and other different elements are going to travel within the cell. They're basically pathways within the cell to move stuff. But most of the stuff is actually moving where, though? Not through pathways, but in what? In that fluid, right? Which was called what? Cytosol. All right, a whole bunch more of these organelles. The Golgi apparatus, and again, a lot of these, I don't even have these memorized, so I'm just reading them off the card. But they concentrate and pack secretions and pack special enzymes. So basically what this is going to be is the secretions would be, could be waste products from the cell, could be other things that the cell is, if it's secreting hormones, it could be the hormones that they're secreting. So it's getting them ready to be able to be secreted in and out of the cell, but it's not mixing it with all the other cellular content. So it's basically, it's a pocket separating what the cell's making or accepting when it doesn't want it to get mixed with that cytosol fluid. Okay, lysosomes dispose of cell waste using enzymes. So it could be some of the enzymes from the Golgi apparatus, but this is where it's going to dispose of the cell waste. Microfilaments is for cell movement and contraction. So why would a cell ever need to contract? One thing might be if due to the osmosis of it, it's getting too much pressure inside of it, it can try to contract a little bit to try to force some of that fluid out. Doesn't work very well. Most of the times when you're getting too much fluid in a cell, what will happen to the cell? It'll actually burst. It'll get so full. They'll stretch. They stop working very good because there's too much pressure within them, but a lot of times they lyse or burst. Okay, the mitochondria. Again, I can't say, but if I was going to test somebody on a cell, this would be probably the one thing I'd put in there, because this is the power of the cell. Think of it like a battery pack of the cell. This is where all the power is stored to help run that cell. All right, peroxisomes, they speed up biochemical reactions. How they do it, I don't know, beyond me. It's way too deep for that, but just know that that's what they do, speed up biochemical reactions. And the other two I'm just going to breeze over because it doesn't really matter. Okay. Within the cell, one of the largest structures, or the largest structure, is the nucleus. This is kind of like the brain center, the control center of the cell. It's going to help make sure that the cell is doing what it's supposed to be doing and everything in it's working like it's supposed to. It also contains the genetic instructions needed to synthesize proteins and determine the cell, functions. And in the book, and I didn't even realize this until I was reading your guys' book last night, it said that every single cell has the ability to basically control all the functions of the body, even though that's not what every cell does. They're real specialized. But it says every cell has the information within it to control all 100,000 different functions of the other cells, which is amazing. But that all comes from the nucleus. Okay. So the life cycle of the cells, they reproduce in basically a form of reproduction, or either splitting and making themselves into two different cells with the combination of a second cell and the sex hormones or the sex cells. Or in the other case, I said they'll just divide and make daughter copies or duplicate copies of themselves. This happens usually 40 to 60 times in the life of a cell. So one cell will keep reproducing itself 40 to 60 times before it dies. Think about that. If every cell is reproducing itself by 40 to 60 times, that's a tremendous amount of growth. But it also means there's a high mortality rate for cells. There's a lot of things that kill cells off, good and bad. And so they have to reproduce themselves a lot to keep up. Okay, the interphase of the cell cycle is just the cell itself preparing to divide. So what are all the different reactions that have to happen within the cell when it's preparing itself to divide. The mitosis or cell division, this is where if it's going to be for a new, like for a baby being born and it's going to be the sex cells, where the chromosomes divide by half, split. In the other case is where they're just making duplicate daughter copies of themselves. And then the differentiation is where the cells become specific for a certain function. Like it becomes a muscle cell, it becomes a neuro cell, it becomes whatever cell it is. That happens as well towards the end of or during the life cycle of the cell. Steve or Pete, can you guys see if other questions are popping up too? We just let me know if anybody has any. Okay. Interphase. Did I talk about that already? I did. Or did I? Okay, cell division and growth occur at approximately the same rate as cell death. So that lets you know, again, if each one's dividing multiple times, having all kinds of little kiddo cells, that there's a high death rate for these poor cells. Okay, now sometimes, though, cell division goes awry. And there's times when their cells either are dividing, it might be a normal cell that's not bad in function, but it's just dividing way too rapidly. Or there might be some problem within the cell, and it's making the wrong type of cells. But either way, you have a time when cells are being produced that are not supposed to be there. What's a big term for what's occurring when that happens? Cancer. If you have cancerous cells, you have problems with cell development, cell growth. Okay. Now, sometimes they're encapsulated. Okay. If you have a bunch of cells being produced, but it's encapsulated, it's not mixing with all the other cells, what is that called? It's a tumor, but there's a benign tumor. Benign kind of is a key word there because it means it's not intermixed with the other normally functioning cells in that particular area. What is the good thing about a benign tumor? You can go in and take it out. It's much easier to do surgery to go in and take this tumor out because, again, it hasn't mixed with all the other cells in the area. Now, a malignant or a malignant tumor is where it is intermixing with other cellular cells around in other tissues. Okay. Now, if that is just still isolated to an area, but it's intermixed with those tissues, they can still sometimes go out and remove it. If it's not going, if removing because you're going to have to remove the good tissues as well as the bad malignant tissues in that particular area. But if removing those good tissues isn't going to cause the patient to die, they'll still go and rip a bunch of that stuff out. What happens, though, is when that cancerous tissue gets into areas that you can't remove, you can't surgically take out, where it becomes a problem, then how do you treat that? That's when you're going to have to treat it with meds, like chemotherapy, radiation, other means of getting those cells taken care of than just removing them. So we're not going to get deep into that, but just know the difference between the benign, which is all by itself and encapsulated, and malignant. Now, if a malignant tumor also travels to other organs and other places of the body, what is the term for that? Metastasize, which is even worse because now you have lots of areas you're trying to treat cancers. Now, just because it's a cancerous cell or a cancerous growth, as you guys know, there's lots and lots of different types of cancer. Some we have gotten pretty good at medically treating. Others we still are horrible at treating. And they all grow at different rates. Okay. The ones that are easier to treat are the ones that go, what do you think, grow faster or grow slower? Grow slower. Because the slower the cancer cell is growing, the easier it is for us to treat it before it's making so many more copies of itself. The ones that grow rapidly are the ones that are hard to control. And one of the more rapid growing cancers that we still have a very difficult time controlling, just one example is when you get cancer of the pancreas. people don't survive that often more than just a few months. And the other problem with that, with pancreatic cancer, is if it's not encapsulated, if it goes into that area, it's so vascular. There's so many blood vessels and other things around it. Oftentimes they can't even do surgery on it because they have to take out so much stuff that the surgery itself will kill the patient. Every now and then people get lucky and can survive, get surgery and get it taken care of, or can get chemotherapy and radiation or whatever and get it taken care of. But oftentimes pancreatic cancer, you're gone within a few months. I've known quite a few people just through my time in the ED and at work where, somebody will come into the ED complaining of abdominal pain, they'll get diagnosed with pancreatic cancer, and they're gone within 2-3 months. It's really, really rapid. Okay, cellular respiration. Basically, it's sort of like when you think respiration with our body as well, but this is the cell itself, getting the nutrients and stuff it needs. It's not breathing per se, it's just getting the nutrients it needs to survive. So what does a cell need to survive? And it's when we talk about the body needs to survive, right? Glucose and oxygen. It's because the cells need it. That's what the cells live on. Glucose, oxygen, glucose, oxygen. There's other things too, but those are the big things. Make sure I'm not missing something here. Okay, so part of this is the body's ability to make energy and use all this comes from glycolysis, okay? And I'm trying to decide how deep I want to go into all this stuff with you. All right, I'm just going to keep it fairly simple. So there's two different kind of forms where the body can make energy or make ATP. And ATP is just a product of energy, or it's like energy credits. You can almost think of it that way. Now, how much ATP is produced depends on one basic factor. And what is that? The presence of what? Oxygen. You're going to get more ATP or less ATP with oxygen? You're going to get more ATP if you have oxygen, okay? Now, if you don't have oxygen, can your body still make energy or make ATP? Absolutely. When you're working out and your muscles are working hard, okay, are they going to start burning more glucose and oxygen than you're getting to it if you're working out super, super hard? Eventually you are. You're going to tax that muscle cell more than you're going to feed it, okay? But there's still a way that it can still produce energy even though you're not giving it as much oxygen. Now, they're not going to produce the amounts. You're going to get ATP, and you're also going to get a byproducts. What are the byproducts it's producing? Lactic acid. Okay, and so when you get done working out and you've overtaxed the cell, these muscle cells, and your muscles are sore, that's from the buildup of lactic acid. That lets you know that you were causing more work for those muscular cells than you were feeding it with oxygen. Okay, is that a bad thing? No, I mean not in certain terms. I mean, if you did it nonstop without giving it rest, it would be bad. But it's fine to tax your muscles and they'll recover. And what'll happen too is once the muscles are getting taxed, like man, we're not getting enough oxygen or glucose when we're being used, they're gonna start doing what? Making more muscle cells, okay, and more ability to access those resources. And so what happens to your muscle? It enlarges. Okay, you're getting bigger and stronger, and that's all from this cycle. Now, the Krebs cycle is a complex pattern of how this entire process happens when you have oxygen. This is not anaerobic. This is aerobic, so there's oxygen there. I'm not going to go over the whole Krebs cycle with you guys. Just know this. The whole process that the body goes through of utilizing oxygen and glucose and everything to make energy, make ATP. I would not spend a whole lot of time memorizing the Krebs cycle. Okay. Cellular transport mechanism. That's a big term for what? All it is how stuff gets inside and outside of the cell. How stuff gets through that cellular membrane. Cellular transport mechanism. Now, is there a certain ratio of fluid and other stuff that the cells like to have within it? Yes, it wants to have, it doesn't want too much fluid in it. It doesn't want too little fluid. It doesn't want too much or too little of whatever the functions are within that cell that it needs. You know, if it doesn't want too much sodium or too little sodium or potassium or whatever it is that's controlling that particular cell. Having it at its normal level of not too much and not too little, that normal happy state is called what? Homeostasis, okay? So then the cell is continually moving stuff in and out to maintain homeostasis. Now, are there elements outside of the cell that might affect that? Think about somebody with congestive heart failure, okay? What's a problem, and let's specifically talk about the cells within the lungs. What's a problem that those cells are going to experience when the patient has congestive heart failure and a buildup of fluid? So now in that interstitial space between all those cells, there's a lot more fluid, right? In order to maintain homeostasis, what's going to happen to the fluid in the cell? It's going to keep getting bigger and bigger because there's a lot more fluid outside, you know, and the cell inside is going to keep getting bigger and bigger, getting more and more fluid inside. Well, that's not necessarily good, right? That's negative. So things outside of the cell can have positive or negative effects on it, and that would be a negative effect on it. So in that case, is the cell going to be able to protect itself? Nope. We have to protect it by introducing other means to get rid of the fluid for the patient, because eventually, if it's untreated and it gets super, super, super bad, all those cells are just going to fill up with fluid and lice, and the patient will eventually die. So there are some ability through this cellular transport mechanism for cells to self-regulate, but there are a lot of outside controls that allow that not to happen. Okay, so diffusion is a passive process. So in this, either fluid or electrolytes or whatever it is that's going to move across a membrane is doing it passively. So it's going to go from an area of higher concentration to one of less concentration, correct? Because it's trying to keep that concentration equal. But it's a passive process. It doesn't require a special enzyme or a special chemical or a special process to get it from one side across this membrane to the other side. Other times, they do require, for other mechanisms, oops, what did I just do? That one. Other times, if it's not going to be through diffusion, there are certain chemicals or enzymes that have to be present to move something across that lipid barrier into and out of cells. Okay. And we do not need to know all the specific enzymes or whatever all of those are. Just know that diffusion is passive, and other times it's more of an active process where things are actually moved through carrier proteins, typically, from one area to the next. Okay, so one area, facilitated diffusion it's still diffusion. It's still cells passively moving from one area to the other. And this mostly happens in the kidneys for this, but not 100%. But in this case, since it's facilitated, that's the key I'm looking for. Facilitated, in this particular case, it does require an extra enzyme to get the things moved in and out of through that bilipid barrier in the cell. Now again, what that carrier molecule is, or the enzyme or whatever it uses, there could be hundreds and hundreds of those different things depending on the particular cell. But just know now it has to have something to facilitate that movement. It's not going to gradually go from higher concentration to less concentration just by simply passing through that bilipid layer. Now the cell itself is going to say, okay, yeah, it's higher concentration over here. We need to get whatever that object is into the cell, but it's only going to let it happen if it's facilitated. So if there's some sort of carrier molecule that's going to go up and grab that item and pull it across through that lipid membrane and bring it inside. So for that to work, though, all of those carrier molecules have to be working properly and there have to be enough of them in the right amounts. Because if there's a problem with those, even though the cell might need something to be moved inside of it or moved out of it, if the carrier molecules can't move it, what's going to happen? Nothing. It's not going to get moved, right? So that just all has to function properly in the right amounts in order for this to work. Again, you guys about ready to get out of the cells? I am. Okay, so osmosis, again, this is a passive process. It doesn't require any chemical reaction at all. This is just moving a solvent from an area of low concentration to a higher concentration. And so here's an example. We've been talking about the cells getting over full of fluid. So in this picture, the cell on the far left is collapsed. But what was the problem here? Why did it collapse? Because the fluid left the cell. Okay. Why would a fluid leave the cell? An imbalance in the interstitial tissue around it, right? And it's for some reason that tissue was pulling the fluid. Okay. What typically attracts fluid or pulls fluid? Salt. So if you have an area outside of the cell which is a higher concentration of sodium, it's going to pull the fluid out of the cell. Okay, so that's where sodium can have a negative effect on the cells. And then you can see the normal cell. The other one is getting swollen or getting too much fluid. So in there, if it's directly related to salt, what's the problem with the salt here? There's too much on the inside of the cell, not enough on the outside of the cell. And so now it's pulling the fluid into the cell. Okay, and then eventually it'll lyse. There's other things that cause that besides just sodium, but that's just an example of how that works. Okay, we kind of talked about that already. Okay, so when we talk about cells, if you have a whole bunch of cells together, they have one type of focus or one thing they do. What is that called? That's called a tissue. Okay. Now, if you have a whole bunch of tissues that work together for one process, that is what? That's an organ. Okay. Now, an organ system is when you have a bunch of organs that are all functioning together for one particular thing as well. They separate our body into 12 major organ systems. And these are, as soon as I find my note card. Okay, so we have the integumentary system, which is what? Skin. The skeletal system, which obviously the bones and all that. The muscular system. Nervous system. Endocrine system. So what does the endocrine system do? That's basically all the hormones in the body and how they regulate the body. Circulatory system. Lymphatic system. What is a lymphatic system for? It's basically waste removal from different tissues. Okay, we'll talk about each of these a little bit individually. Then the immune system, fighting off foreign bodies. Respiratory system, digestive system, urinary system, and reproductive system. So, as again. Just the cellular aspect of this lecture could be really, if you wanted to get really deep into it, that could be a 3 or 4 hour lecture all by itself. Each one of these systems, in a college course, they'll break each into these sometimes into a semester. But we're going to cover all these now, really quickly. Okay, skeletal system. The skeletal system is what? Is it only bones? Take ligaments and tendons are lumped in here too. Basically, what you need to support yourself and to be able to move. Okay. Now, oftentimes, I don't know why, my brain has lots of problems, but one of the problems in my brain is remembering the difference between ligaments and tendons. I, for the life of me, outside of a class, can never remember what is what. But there are differences between the two. The ligaments connect bone to what? Bone to other bone. The tendons connect muscle to bone. Now, do they all have to work together? Absolutely. You have to have them all functioning appropriately, but those are very specific. There are very specific differences between the two. From our perspective, though, if you're treating somebody, let's say they, injured their ankle, can we tell if it's a ligament or a tendon that was injured? Not really. There's no way to know without. Even X-rays aren't going to show that. What's going to show that? An MRI. Okay. Do X-rays even show ligaments or tendons at all? They don't. You might see kind of a shadow of it, but you can't identify it. They're only showing bony structures on X-ray. So basically, if we bring somebody in that has some sort of musculoskeletal injury, the first thing they always do, almost all of them, is do an X-ray. All they're looking for there is to see if there's a fracture. And then if it's not a fracture, it's like, okay, well, it's not broken. Something else might be wrong. They'll have to do an MRI or some other sort of scan to figure it out.
Well, sometime later.
Yeah, it's not always done on site or at the ER for sure.
Sometimes depending on the structure you're looking at too, you can check the other side of the body, see if there's inflammation between the bone and the structure you're looking at.
Uh-huh.
Tell if it was muscular.
To a point, yes, you are correct. All right, cartilage is just in between these bony structures as a protective mechanism, at least as far as the axial skeleton is concerned. Having two of these clickers is going to kill me here. Okay, did that. Sorry, just making sure I'm in the right spot. Okay, bones. Bones are classified based off of what? Their shape, okay? They're either long bones, short bones, flat bones, or some irregular bones, okay? So what are a couple examples of the long bones? Femur, tib, fib, radius, humerus, the bigger bones, okay? Short bones. Little ones. Are they still long and skinny, but not big like a femur? I mean, they're not irregular shape like the phalanges and the metacarpals and metatarsals and stuff. They're still straight bones. They're not irregular shaped, but they're just little. Okay, what would be some flat bones? Okay, scapula. Some skull bones they consider mostly, or a lot of the skull bones are mostly flat, even though they're a little bit rounded, they're still flat. Ribs, they actually consider flat bones. And then your sternum. Okay, and then there's some irregular bones. Where might some irregular bones be? What was that?
Spine.
Yeah, I would think the spine would be irregular. Okay, a lot of the bones, like the little teeny tiny ones in your ear, are irregular. I think they consider the pelvic ring irregular too, but I'm not 100% sure on that one. But I don't know where else it would fit. Maybe flat, but I think it's irregular. Is it for the irregular? Thank you. Okay, so when you look at a long bone, there are specific elements of the bone itself, or regions of the bone. So the shaft is called the diaphysis. The end is the epiphysis, if I'm pronouncing that right. And then there's also a growth plate near the end of the bones. What is one thing that happens within the bones, though, that's important to know? What do bones produce? What type? Yeah, they help produce blood. So that happens in the bone. Now, does that happen more in the long bones, flat bones, irregular bones? I initially thought it was long bones too, but it's not. It's more in, I think it said the pelvic region, and there was another, I'll have to get to that here in a little bit. But I always, in my mind, thought it was long bones. It's not. And there's a reason for that. They don't produce as much blood because it the area where you need it to produce blood is more of that string-like softer tissue, and they lose the strength. And so the ones, you think like a femur, it's got to be really, really strong. And so it's thicker, heavier, more the dense material. So there's not as much area for it to produce blood. The bones that might be structural but not need this severe strength load is where most of the blood is produced. All right, how many bones are in the body? 206. When we talk about the muscle skeletal system, how many muscles are associated with those bones? 600. 600 muscles. We'll have you memorize all of those by the end of the class? Okay, maybe not. 206 bones, 600 muscles. And I didn't specifically talk about one of the, I skipped over somehow on the slide. They do separate your muscle skeletal systems into two groups. The axial and the appendicular. What is the difference between the two? What is your axial skeleton? Skull, thoracic cage, and vertebral column. All the rest. So does that part of your exoskeleton have tons and tons and tons to do with just regular movement? Not as much. The rest of it that really helps you arms, legs, and helps you move around more, and pelvis is the appendicular skeleton. Don't know how important that is, but they did specify that in the book. Okay, joint. What is a joint? Very simple. Just a very simple definition of a joint. Where two bones come together and hinge, correct? Now, there's lots and lots and lots of different kind of hinges that the joints could have. Some basic ones, though, would be what? What are a couple of the basic hinges that our body uses? Ball and socket, which is an example of what joint? Okay, shoulder is a good example of that. Okay, so a good thing about a ball and socket, it has more movement options. Okay, more or less stable though. Less stable, more prone to injury. Okay, and then what would your knee be? What kind of joint, or your elbow? What kind of joint would that be? A hinge joint. Okay, more stable, stronger joints, less likely to be injured, but I mean, still capable, but they're less likely. All right, we just talked about those. Oh, maybe I was ahead of myself. That's why I didn't mention it earlier. So here's your axial skeleton and appendicular skeleton. Okay, so just the skull itself has 28 bones in it. A lot of these are just fused together. They don't have joints like other bones do. Because does your skeleton or your skull move much? No, not really. So even though like you look at your skull itself, there's lots and lots of different bones in it, but they're all fused together. Can you tell the difference between any of those bones from the exterior, other than just knowing where it should be? Nope. We can't like palpate the skull and feel the difference between different parts or different bones within the skull. Now, obviously, if you removed all the skin and everything else and you were looking at just a skull, you can see all those suture lines, but you can't see it or tell externally other than just knowing, yeah, this part of the skull is called whatever it is, depending where you're palpating. I am not going to sit here and go over every single bone in the body with you. You guys can read and memorize those as well as I can just sit here and tell them to you. All right, what is the cranial vault? This is the main part of your skull bones creating the vault within your head. Now, there's other bones that are part of your head and face, but the cranial vault are just the big ones that actually make the vault. We're not talking as much about the facial bones here. Okay? And again, these have all these suture lines between them, and they also have the fontanelles. Now, how many fontanelles do you have in your skull? 2. Well, there might be little ones, but 2 main ones. The anterior and, is it just posterior or is there another name for it? I think it's just posterior. Yeah, anterior and posterior fontanelle. Okay, so the anterior one is almost more on the top of your head, and then the posterior is towards the back. Now on us, can you clearly identify where those fontanelles are? Some people you can actually still kind of feel where they were. I can feel where my posterior fontanelle was, even though it's now closed with bone. It's not an open spot into my head. But sometimes you cannot feel where those are. Who can you tell? What population can you easily feel where those are? Little babies, kids, okay? Because they are not completely fused yet. Now, is there any usefulness to us with those fontanelles that could be used in EMS to tell us anything for children? Yeah, cranial pressure. If they have high cranial pressure, what would you anticipate seeing with that fontanelle? A bulge there. If they're, really, really low on fluids and they're really super dehydrated, sometimes you will see a depression there, but not always. It's not 100%. But if you have time and you think about it, yeah, look for the little fontanelles and just see if they seem normal or not. But again, eventually, those do grow together. I don't know on the top of my head what age that is when they actually grow together. But. Okay, so here we're talking more about the cranial vault. So this is the floor of it. So this would be when you're thinking about the skull. Again, we're not talking about the face. We're talking about the skull itself. But this is the bottom part of the skull, the floor of that skull. So they've basically cut the skull into. They've cut the top of it off, and these are just the sections of it. So the anterior part of that, again, it would be if you're looking at a person's head or skull, you're looking straight down upon them, okay? The anterior part would be what part of would it be their nose or would it be the back of their head? So it's going to be where their nose would be on the anterior part of that cranial vault. Then the middle fossa is just a center section, which would, house just the middle part of their skull. And then the posterior section where the occiput and stuff rests is the back of the skull. But what's an important feature of the posterior part of the cranial vault? What happens there in relation to the rest of your body? That's where your foramen magnum is, where the spinal cord and all that comes in. It's actually more in the posterior aspect of your cranial vault. A lot of people think it's right in the middle of your head. It's really not. It's more in the posterior aspect. All right, here's all these beautiful colored pictures. My daughter was looking at me this morning when I was preparing for this. She's like, why did they color all of those? Well, all it is so you can identify the different bones. Because, again, they're all fused together, right? It's not like an arm bone where you can really see the humerus or the tib fib of your leg where you can clearly identify it. These are all fused into one series of bones. So in order to identify them, they almost have to color them so you can easily identify which is which is which. Again, I'm not going to sit here and read the names of all these different bones to you. Just know there's a whole bunch of them that make up your face. It is important to know them. Just because I'm not going to sit here and read all the names off to you in class doesn't mean you shouldn't spend some time knowing at least the major ones, like the maxilla, the mandible, the temporal bones, and kind of the main structures that lie beneath them. But it would just be a waste of your time for me just to sit here and read off this picture to you. All right, so bones of the orbit. When we talk about the orbit, what are we talking about? The eye. So these are the bones that make up the structural support of the eye mechanism. So obviously, since it's the eye, it's going to be a cone-shaped kind of bony structure to allow for the eye socket and everything else. It does contain blood vessels, nerves, fat in the area. And then if you have a fracture of the orbit, what's the common term for that? They call it a blowout fracture. It's why they get a specific name for that. It's just called a blowout fracture. But oftentimes, because of where the orbit is and because of how that fracture is, you can get blood and different other things that leak into the maxilla area of the sinuses. So just know that. But if you think about that, if you have a eye injury that you have stuff leaking into the sinuses, what'll be a sign of that you'll see externally? So if you have a fracture that's dumping a lot of blood that you can't see posteriorly into the sinuses, where's that blood going to go? So if you have a patient that has a bloody nose, but you don't think they got hit in the nose. Their nose isn't hurting, but their eyes all, maybe bruised or deformed or a lot of pain. Just think to yourself that that's probably where the blood's coming from, is from the orbit, not from the nose itself. Okay, nasal bones. Now the problem with these is they're fairly little, right? A lot of the nasal bones are not real. There's not a lot of strength to them, so they're easily fractured. But in your actual nose itself, what is your nose mostly made of? Is it bone or cartilage? Luckily, most of it's cartilage, so it doesn't matter. But the actual nasal cavity bones, not just your nose, but up into your nasal sinuses and cavities, a lot of those are fairly small bones. Okay, what is the mandible? Your lower jaw, right? Okay. And the important thing to know with the mandible is it's not fixed, so you can eat. So it's got the mandibular joint, right? What can happen, though, because of that joint if you get an injury? Okay? You can get lockjaw from different things where their jaw cannot move, right? Now, a bad thing we think about if a patient has a mandibular injury where their jaw can't move, one thing most people think about right away is, man, how are they going to eat, right? Do I care about how the patient's going to eat in EMS or to? No. Okay. What do I care about with somebody that has that locked jaw? Well, yeah, how am I going to manage their airway? That's the problem with the mandible fractures or issues. And sometimes, even with us, it's easy for us to, I guess, not understand the importance of this. I mean, for example, I actually had a case where I brought a patient in this summer that it was a wakeboarding or a kneeboarding accident in the lake. The kneeboard just popped out from under the guy, came up and hit him in the neck. Well, I could tell his jaw was broken. It was offset a little bit, and he couldn't really open his mouth a lot. But he wasn't having any difficulty breathing. He was maintaining his airway fine. He also had a significant laceration to his neck, which had very little blood. It was just a huge, big laceration, but it's mostly soft tissue. Was I concerned about the guy? Yeah. That I think he needed to get in right away? Yes. I didn't call a priority 1 trauma on him or a level 1 trauma. It's like he's got a jaw fracture and a laceration that's the bleeding's controlled. Man, that ER, when I brought him in, they immediately upgraded him to a priority 1 trauma. And so I was talking after to the chaos, and they had to move rooms because they put us in one of the side rooms, and it was kind of a big mess. And I could tell the doctor wasn't really impressed with me. But I went and talked to him later. It's like, okay, well, what was your big concern? Why the huge upgrade? And it was 100% airway. He's like, well, it wasn't the neck injury. He's like, I was worried about, even though that's what looked bad. He's like, it was the fact that he could not maintain or couldn't open his mouth, and he couldn't. It was locked, even though he wasn't struggling to breathe. The mandible was fixed. It wouldn't open. He's like, we were just preparing for the worst just in case. He's like, because what if all of a sudden he develops an inability to breathe very well? For them, in EMS, what is our option? Can you tube the guy with a mandible that you can't open? Not really. You could try, but it's probably not going to work. You could try to go intranasally. Whether that works or not, who knows? But really, probably they're going to end up getting criked. Okay. Well, in the hospital setting, so in our setting, if we're thinking you have a patient you need criked, who do we want there? Who are you guys going to want to make sure you have with you? A paramedic, right? Well, in our system, every ambulance has a paramedic on it. So it's not like we're having to think outside the box like, man, we got to get a paramedic here, unless you happen to be working like a callback or something. But in the hospital, they just look at that a little bit differently. If they have a patient that they think they might have to crike, even though technically the ER doctor could do it, he's not going to plan for that. He's going to call the whole, surgical crew that comes for a priority 1. So he can pass that off into anesthesia and the surgeon and not have to worry about it. So it wasn't as much that he was upset that, man, we needed all these people here right now. This should have been called. And even he's like, it's technically a level 1, but he's like, I don't care that you didn't call it. But he's like, here, we're going to call it just to get the resources here, just in case. So kind of went off on a tangent there. But just know, when you talk about the mandible, the big thing we need to know with that is if there's a problem with it, isn't the mandible itself. It's the airway behind the mandible that we need to be worried about controlling. All right. So the neck, lots of different important structures in the neck. So we have bony structures in the neck. We have muscles in the neck. But are those the super important structures within the neck? Not really. What's the important things? Okay, so the airway is super important. So what are the other important things within the neck? The spinal column, and I'm not talking about the bony stuff itself, although that's definitely related. I'm talking about the spinal column with all the nerves and stuff that goes through that, right? Because really, that's what we worry about. I don't want to say I don't care if they have a broken neck, but I don't care if the bony stuff is broken. I care about the nerves in the middle of all that broken stuff. But if they have a broken bones, that in their neck, we have to worry about the nerves. But it's the nerves that we worry about. Okay, what are the other things in the neck that are major players for the human body in importance? Big blood vessels, right? Both veins and arteries. So what are the major arteries in your neck? The carotids, and you have how many? 2, 1 on each side. 2 carotids and 2 which veins? Jugular veins. Okay. Now, obviously, if the patient gets a carotid artery that is torn or cut or ruptured or whatever, it's a huge deal, right? They can lose lots and lots and lots and lots and lots of blood really, really fast. We usually don't think about veins being a huge deal if somebody lacerates a vein because it's not high pressure. But jugular veins are really big veins, okay? And if they rupture or cut a jugular vein, even though it's not going to be high pressure squirting out of it like an artery, they can still lose a large volume of blood from that particular vein just because it's so big. So just keep that in mind. But yeah, those are the big things in the neck. Now you also have, specifically with your trachea, you have some cartilage associated with your trachea. What are the terms for those? There's 2 specific ones I'm thinking of, and I don't know if you're on the same page as me or not. The cricoid and thyroid cartilage. A lot of us think about cricoid right away in EMS because of what? We use it to help with airway control. Either helping manipulate the airway to help somebody get a breathing tube down into the trachea, doing that Celix maneuver with the cricoid ring, or simply taking that cricoid ring and pushing it down to occlude the esophagus to help prevent what? Aspiration. Okay? So a lot of us think about the cricoid cartilage right away. But it's actually the smaller cartilage of the 2. The thyroid cartilage is much bigger than the cricoid cartilage. And is it above or below the cricoid cartilage? Above. So it's thyroid. Then you have a membrane in there. It's the cricothyroid membrane. And then the cricoid ring or cricoid cartilage below that. Okay. Now, guys, you can typically easily see where the thyroid cartilage is because it is what most people refer to as what? The Adam's apple is the thyroid cartilage. Now, most of you could probably feel your thyroid cartilage, feel that little soft little hole underneath it. That's the cricoid thyroid membrane. And then right under that is the cricoid ring. Okay. Then the significant thing about the cricoid ring, it's one of the few tracheal rings, that might be the only tracheal ring, that it's a complete circle. Okay? So when we talk about airway, and now I have a complete circle around my airway, what is that a good location for? An obstruction. Because if you have something big that's trying to pass, that gets into your airway, and it gets to that point, the tissues can't expand to let it go any further. It's going to get stuck right there. Now, if it could expand, that would be great, because we still don't want foreign objects in our trachea, right? But if we can make that tracheal openings get bigger all the way down to one of the 2 main bronchuses, what can we do with a foreign object? Just jam it down in there, right? And we can get it to one lung or the other. And then can you live off of ventilating with one lung? Absolutely. So that would change the game for us. If all of the tissue had the ability to expand, and we could just take it somehow, get some device where we could shove stuff down. But it doesn't work that way, because oftentimes it's going to get stuck at that cricoid ring. So just keep that in mind. Now, what is significant about that cricothyroid membrane when we talk about in EMS? That's the location where you're going to, if somebody had to get an advanced, tracheostomy or something placed in the field, that's where it's going. Yeah. All right, spinal column. There's different regions of the spinal column with different number of vertebrae, but it's 7, 12, 5, 5, 4, 7 in the cervical region, 12 in the thoracic, which corresponds with what? Your 12 ribs, okay? And then the lumbar with how many? 5. The sacral or sacrum, 5, and then 4 down at the very bottom at the coccyx. All right, so now with the spinal column itself, we kind of talked about that, where it enters that foramen magnum at the brain, but it travels all the way down to what? Basically the bottom of your whole spinal column, right? Down towards it doesn't go through the coccyx at the bottom. It kind of breaks out before there, but it exits right at the bottom of the sacral area. Okay, so that's your spinal column. Now, different areas of the spinal column control different parts of your body, correct? And the lower you go, the lower it's controlling in the body. The higher you are, the more functions it controls. Now, there are specific areas that relate to specific nerve tracts that they can all track, the dermatomes. So those are basically a specific nerve tract that controls a certain part of the body has its own dermatome. You guys don't need to know what all the dermatomes are, but they just separate them that way. The spinal cord itself is protected via what? The vertebrae, right? But the problem with our body, with the vertebrae protecting the spinal column, ideally, if we really wanted to protect the spinal column, how would we protect it? If we really didn't want that thing to get messed with at all, it would be more like our brain, right? It'd be a thick piece of bone. It would be isolated. It would be strong, and it wouldn't move. I mean, that would really protect our spinal column the best. But then, that's really going to impede our ability to move around. So our bodies weren't made that way. They were made so our vertebrae all move to allow for movement. But with that, it also makes our spinal column more apt for injury or problems. Okay, thorax. What are we talking about with the thorax? Chest cavity, right? So the ribs, where they attach to the mandible. In the back, they go around and attach to the vertebrae. That whole area is the thoracic area, including the scapula, the clavicles. All of that are all kind of part of this chest cavity. I'm trying to think how deep I want to get into some of this. You know what? Let me finish up the thorax, which I don't think there's much. I'm not going to talk about that because you guys already know it. All right, I'm going to stop here just to let you guys get up and stretch for a little bit. We want 5 minutes? Is that enough, or we want 10? 5 enough? 5 minutes. All right, take a quick 5-minute break, stretch, grab some coffee, and then we'll keep powering through this exciting material. this mess here. You're good.
I don't know wherever you were.
I don't either. Hopefully I skipped about a dozen slides, though. All right, so we're just talking now just kind of specifically about the appendicular skeleton. So it started out talking about the shoulder girdle, shoulder joint. And we already talked about how the shoulder is what type of joint? Ball and socket. Okay. Again, I'm gonna try to breeze over these guys because this stuff we could spend for hours just looking at anatomy pictures and talking about what each one is, but we're not going to. The upper extremity is your arm, forearm, wrist, hand, fingers, and all the bones, that correlate with all of that. Again, so your arms and legs both have a section where it is a single bone and a section where it's two bones. The top portions of either one, so the humerus in the arm is by itself, and then what are the two bones in the forearm? Radius and ulna, okay? All right, and lots of little bones that make up the wrist and then the hand. So the metacarpal bones and phalanges in the hands. And if you decide you don't want to talk about, the specific, name for each one, you can also just say digit 1, 2, 3, 4, 5. But do you know where it starts? If you're going to start with 1, it starts with your thumb. So digit 1, 2, 3, 4, 5. So you can also list them that way. It's easier than remembering specific names for each individual finger. All right, pelvic girdle. Is basically everything that makes up your pelvis. So even though it's a ring, does it sit straight in your body as a normal ring this way? It's angled. Which way is it angled? Tipped forward. Okay, so it's a forward-facing ring is what makes up that pelvis. Now, with pelvic fractures, the problem with if you damage your pelvis, what is the problem with pelvic fractures when we talk about the ability for the patient to do well or not? When they split, they bleed a lot. You can lose a lot of blood in a pelvic fracture. So that's a concern with your pelvis. Again, you're going to talk a lot more about that when we get into the trauma and that particular area. But just know that the pelvic girdle is very vascular, and you can lose a lot of blood in there. And there's lots of different types of fractures you can get with that. But again, you're going to talk about all of that again when we get to trauma. Okay, your lower extremity, you have your hip, your thigh, knee, leg, ankle, foot, toes, all of that. Now, a lot of people get confused with the hip and the femur. And really, it's because of how they named it. Because is there a structural difference between the femur and the hip? It's all one bone. Okay, so what is the hip compared to the femur? The hip is the top of it. Now, sometimes they'll call, sometimes if you fracture the pelvic joint, they'll call that a hip fracture too. But technically, the hip is just the top part of the femur. So it does get confusing. So when we're trying to figure out, man, did they break their hip or did they break their femur? Well, it's the exact same bone. It's just where they broke it. So if they broke it up near the top, whether it's the head of the femur or even down a little bit into the top part of the shaft, that's all called the hip. Okay. So for us, if it's femur, we're thinking more like mid-shaft or below. If it's mid-shaft or above, it's just kind of consider it. If it's, anywhere in this area where you can't identify where it's at, but above the midpoint of their thigh, it's a hip fracture. But again, it's the same bone. Are you going to treat it much differently or any differently? How do you treat a broken femur differently than a broken hip? In some instances, traction. But you're only going to put a traction splint on what type of femur fracture? It has to be mid-shaft, right? So if it's not mid-shaft and it's above that, it doesn't matter if it's what part of the femur or hip. you're not treating it any differently. We're going to immobilize it in a position of comfort. Usually we don't put any kind of splint on those. We'll just get it where they're just comfortable on the gurney, and that's fine. But it is confusing since it's all one bone with two separate names. But please, 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 please do not put traction splint on a hip fracture. I've actually seen that a few times. It's been a while, but when I worked in the ED as a nurse, there were a handful of patients that would come in with hip fractures that were in traction splints. And it's like, ugh, please don't. So my thought on traction splints are, unless I'm 100% sure, with no question at all, that it's a mid-shaft femur, if I don't know that 100% with zero doubt, they don't get a traction splint. If I know it's a mid-shaft femur and I know that for sure, I'll put them in a traction splint. Okay, but you have to know that 100%. What else might happen though? A lot of times if somebody fractured their femur, could they also fracture their hip? If you have both, are you going to put them in a traction splint? No. So if they have pain up here as well as mid-shaft femur, I'm still not putting them in traction. It has to be an isolated mid-shaft femur to get traction. Now, does that mean we don't splint it at all? No, you can still put them in a splint. Just don't put them in a traction splint if you don't know it's mid-shaft femur. Okay, so the knee, issue with the knee above just the joint is all the ligaments and tendons and muscles and stuff that help control your knee and movement of your leg. Oftentimes, when we're talking about injuries with the knee, is it actually the structural knee itself, the bony part of the knee? Rarely. What is it usually? The tendons, sometimes ligaments, but yeah, it's rarely the bony part. Now, it could be the bony part, but usually it is not. Now, when I tend to see knee fractures, when it's the bony part, what part of the bone is more common to fracture? The patella is actually, if you're going to actually fracture a bone in the knee, oftentimes it's the patella. Because when you fall knee first, that's the first thing that's going to hit, whatever it is. So usually it's the patella. What is the problem when you get a patella fracture, especially if it splits? What attaches to the patella? Well, first of all, the tendons or ligaments. Tendons attach what? What does a tendon attach? And what is a ligament? Bone to bone, so it's tendon. Okay. If you completely separate your patella, it'll pull them apart. Okay. So sometimes you'll actually be able to see the patella, and you'll see it slide down either part of the leg or up the leg and down the leg a little bit if it completely separates. Very, very painful. Nothing we can do for it specifically other than splint them and take them in. But that'll sometimes happen with a patella fracture. Okay, so then the ankle, again, there's lots of different bones in the ankle, in your foot, in your toes, and all that. You have the talus, which is what? The heel of your foot. Okay, it articulates with your tib fib, your leg bones. That joint, there's, going to give you the flexibility of your ankle. Okay, so again, we're not going to get into pathophysiology in this lecture. This slide's kind of talking a little bit of pathophysiology, but that's not what this lecture is about. This was purely the anatomy lecture. The patho is going to come next, and thank goodness you don't have to listen to me for that lecture. Somebody much smarter, better looking than myself. So that's good. But what is the point of the skeletal system when we talk about pathophysiology? It provides structure, right? But is the structure a pathophysiology thing, or is that a more of just an anatomy thing? The structure is anatomy. The protective mechanism of the skeletal area, though, is more pathophysiology. With how it protects organs, it helps things move around. So it's not purely the structure of the bones itself, it's what the bones are accomplishing. That's the pathophysiology part of that. So moving my leg or my arm around, utilizing muscles and bones and all the nervous system to do that, is pathophysiology part, where the actual structures themselves, the bones, the nerves, the muscles, individually are anatomy. Okay. So there's lots of different things that have to occur to make the pathophysiology system work, which I am not going to get into in this lecture. All right, muscles. How many muscles did I say are in the musculoskeletal system? 600. Lots and lots and lots and lots and lots of different muscles. From little teeny muscles to very, very big muscles. All of them are there to do what? Aid in movement. It's the only purpose of a muscle is to move. Now, does it always mean you're physically moving from, like one space to another, or moving your arm in one direction to another? No. What's another muscle that physically it moves, but it doesn't really move? I didn't hear you. Okay, your diaphragm would be an example of that. The muscle's moving, right? But it's not aiding you in movement. The muscle itself is moving. Your heart's another example of that. Your myocardium. It is a muscle. Your heart is moving, okay, but it's not helping you move in like with the musculoskeletal system part. All right. So one thing that's important to know with the ability for the musculoskeletal system to function and your muscles to work is the fact that those muscle cells use what for energy? The same as all the other cells. ATP, which comes from what? Oxygen and glucose. Okay, through that whole Krebs cycle and all that, it needs ATP to be able to move. Now, they can store a small amount of ATP within the muscle cells themselves. So earlier we talked about when you work out, you get tired and you start, pretty soon you're overtaxing your muscles and you build up the lactic acid. Well, initially, that initial burst of muscle use it's coming directly from the muscle cells and fibers. They're storing that ATP ready to go. So after time, they have to replenish that and rebuild it and get it from other places. But initially, they store that small amount of ATP for that quick burst. Why would your muscles need the ability for a quick burst? Yeah, that whole fight or flight mechanism. You reach down, you put your hand on the hot burner. You have to have that initial store to immediately, quickly pull your muscles back. You don't want to be waiting for your body to get that ATP from somewhere else and get it to the muscle and get it to work. I mean, that would still happen relatively quickly, but you don't want to wait at all. You need that initial reaction time. So that's why they store ATP for their short-term use. All right, we've talked earlier about how oxygen is used, and when you no longer are able to keep up the oxygen consumption, you're burning it more than you're feeding it, you build up lactic acid, okay? And this kind of just talks about that, which we already talked about earlier. All right. Okay, the respiratory system. Again, we talked a little bit about the musculoskeletal part of the respiratory system. We talked about the neck and the airway, but this is actually getting into the actual respiratory system itself. So what makes up our respiratory system? When we start breathing, where does it begin? Mouth to nose, where it starts, right? So that is the beginning of your respiratory system. And it travels all the way through and clear down to the base of your lungs. Then all the structures in between there. What is this is a little bit pathophysiology, not just anatomy, but what is the function of your nares and nasal system when we talk about the respiratory system? When we breathe through our nose, what is it doing? Warming and humidifying and then filtering. All three of those as the air as it goes down. So it's going to pass through our nasal cavity, our oral cavity, and then it'll pass down, start going into the airways, okay? We have our larynx and our pharynx, which are basically just different phases of the airways, and then it's going to go down clear into your trachea, into the bronchioles, into the bronchioles. It's just going to get dividing, get smaller and smaller and smaller and smaller. How small does the respiratory tract get as far as like into your lungs? How small are the functionality of it? Cellular, right? It gets clear down to where it's like single cell stuff. And when we talk about like the capillaries in your lungs that correspond with the alveoli, the capillaries are so tiny that it is a single red blood cell at a time that passes through the capillaries. That's how teeny tiny the capillaries get. And there's miles and miles and miles and miles and miles of capillaries everywhere in your body. But it all has to be that those single blood cells are going through the capillaries. And then you also have the airway tracts that get just as tiny, and they meet up near each other, okay? So when we have a little teeny tiny airway tract and a little teeny tiny tract for the blood vessels, what's happening at that point? What's in the airway that needs to get out into the body? Oxygen. So the oxygen diffuses through the wall of these alveoli, in part of the alveoli. It's a little teeny tiny structure. It diffuses right through the wall into the interstitial space, through the interstitial space and into the what? The red blood cell, which is, in the venous system. In the capillary system. The same thing with the carbon dioxide. It's going to diffuse out of the blood cell into the interstitial space, travel across, diffuse across that membrane and into the airways to be able to be excreted out of the body. So those have to be really close together, right, for those to occur. That's why it breaks it down into such a small structural space, so all of those can be close together. And it's just a huge network of millions of those little pathways talking to one another. The problem is, we talked about a problem with congestive heart failure earlier, how it builds up fluid and can cause your cells to lyse because of the fluid within the cells. Well, what if you get a buildup of fluid from congestive heart failure just in the interstitial space? What's going to happen with that mechanism for that off-gassing and regassing of oxygenation? Right? Because what will happen, you'll get too much fluid in there, and the capillaries and the airways get pushed away from each other. We're talking, microscopic amount of space, but enough space where it's harder for the oxygen to fuse through and get into the blood cells, and the carbon dioxide to diffuse out and get back to be excreted in the airways. So any little bit of fluid in there, and it doesn't take much, can interfere with that process of the respiratory process. So the lower airways contain the trachea, the bronchial tree, the alveoli, and the lungs. And gas exchange occurs at what place? Deep in the alveoli. Okay, the lungs are important to know that there is an outer lining. There's a couple of different linings of the lungs, okay? The lungs just aren't sitting in the middle of your chest cavity just all by themselves. They have a lining around them, okay? And there's actually surfactant or a fluid lubricant in between the lung tissue itself and that lining. Why is it important that there's a lining with the ability to move between those two? Right. It first of all, it makes it so the lung tissue itself isn't tearing because it's adhering or ripping to the side of the protective lining. It just allows for movement. Okay. There are cases though where you get a buildup of stuff in between the lining of that lung, and that pleural lining and the lung itself. Okay. So and when we talk about trauma, you guys are going to learn about like hemothoraxes and pneumothoraxes, where you get blood buildup or air buildup between those linings. I'm not going to really talk about it now, but just understand that when we get to those later, it's that protective sac that is around the lung itself, and then you have the lung. It's the gap between those two where we don't want a excess fluid like blood, or we don't want a bunch of air. Because if you have a bunch of fluid or air in that protective sac, but not within the lung itself, what's going to happen to the lung? It's going to push the lung down, it's going to push the lung down, it's going to push the lung down. And pretty soon you have so much stuff in between that pleural lining and the lung tissue that the lung can't function like it's supposed to be able to. But it's not really, a lot of people think of those injuries being within the lung itself. It's not really inside the lung. It's between the protective lining of the lung and then the lung itself. It's that there's a barrier in there. All right, lots of different muscles are used for breathing, but what is the main one? Big old diaphragm, okay? Other than breathing, what other purpose does a diaphragm have. Just separates the abdominal cavity from the chest cavity. But it's mostly there for breathing, okay? What are some of the other muscles that are used for breathing? Right there on the screen. Intercostal muscles. Okay, where are those located? In between the ribs, up in here. Now, oftentimes, even though they're kind of used with every single breath you take, the intercostal muscles, you don't really notice them. But when people are having severe respiratory distress, and especially if they're not overweight, where you can actually see their ribs, so you see this mostly in children, when they're really, really, really struggling to breathe, you can actually see with every breath they take, their ribs pop out. Well, their ribs really aren't popping out. What's really happening? Their intercostal muscles are pulling in and moving and working. It's that difference between when they're contracting and relaxing. You're seeing a difference between the contraction and relaxing within the ribs themselves. But you really can see them. You can see every little muscle between their ribs working. Those are the intercostals. Okay. So the point of the respiratory system is to exchange gases, right? We've already talked about that. Clear down into the clear down into the alveoli and get them into the capillary beds. So respiration, that term itself, simply is just defined as the process by which gases dissolve in a liquid. But again, when we talk about the respiratory system, it's the whole system to get the oxygen from the external environment into your cells, into the bloodstream, and get all the gases from your bloodstream back excreted out. All right, what controls breathing? Your ability to breathe. Or not your ability, but the way your body is breathing. Right, so it's chemical receptors that are looking for the levels of CO2. Okay, is it oxygen or CO2? I already kind of said it. It's actually a little bit of both, but mainly it's CO2. Is it too little CO2 or an excess of CO2 that starts a breath? Excess. Okay, so when your CO2 level builds up, it initiates the respiratory process to begin. Now, they talk about a lot for our COPD patients. They have a normally elevated CO2 level. So what happens with their respiratory drive? It switches to be more oxygen dependent. It's not 100% though. They say the fear is with somebody with COPD, if you put oxygen on them, it's going to make them stop breathing. That doesn't happen. They still need oxygen if they need oxygen. Just be aware that if we're flooding them with oxygen, it's going to affect their chemical receptors in their body a little bit and exchange how they breathe. But we're not going to ever withhold oxygen from somebody that needs it just because they're a CO2 retainer. But just know that it is a carbon dioxide that triggers your body to breathe, not oxygen levels. Okay, I got some fabulous news this morning that there's somebody coming to teach you acid-base balance. What you're going to do, she will do a much better job than me. And so I'm going to basically breeze over this really, really fast. But what's important to know about the acid-base balance is your body wants to, everything has to be homeostasis. It has a certain area it wants to be. That includes acid-base balance. What is the pH in your body normally? 7.35. There is very, 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 very little room for changes in that before your body has drastic effects. It wants your pH at 7.35 or really, 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 really close to that. There's different mechanisms that are used to help create or keep the pH balanced. But the primary two centers that do that are what? Respiratory system and renal system. Okay? Respiratory system affects these very, very quickly. The renal system is very, very slow. It can take hours to days for the renal system to affect pH, where the respiratory system can affect it much faster. So just know for today that there's acids, bases. There's a buffer system that helps to control this, but for today, that's as much as we're going to get into it because you'll get this more in depth here in a bit. Okay, so when we talk about lungs themselves, we're still in the respiratory system. We talk about the amount of air that gets into and out of your lungs. Now, it's air, right? It's not just oxygen, because there's a lot of other stuff that you're breathing in and out, breathing in and out, breathing in and out. What is tidal volume when we talk about breathing? What is the term tidal volume defined as? Yeah, so the amount of air that's normally breathed into your, during one single breath. Now, when you take a breath, does all the air from the outside always make it into your lungs? No, where some of it gets stuck. Airway, your mouth, your trachea, your bronchioles, before they get clear down into the alveoli. Because really, only the air in the alveoli really matters, right? We don't care about all the other stuff. So the air that doesn't make it down there, what do they call that? Dead air space. Okay, so that doesn't really count towards any of that. So not every time you take a breath, not everything you're getting is going to go into your lungs. So just know that. And your body doesn't even use all the oxygen that it breathes in. What is the concentration of oxygen in the air, approximately right now in this room? 21% oxygen. Okay. Do you guys know the percentage of oxygen you typically exhale during your breath? It's like 16%, 17%. I mean, it's amazing. It's like, wow, we hardly use any of the oxygen that we're actually breathing in. That's why CPR is somewhat effective with mouth-to-mouth, because you are breathing out some oxygen. You're also breathing out a lot of carbon dioxide, but you are breathing out oxygen too. So just keep that in mind. We're not taking in all oxygen and breathing out all carbon dioxide. We're still exhaling even oxygen because we don't use it all. Okay, expiratory, make sure I'm on the right slide here. Reserve volume is the maximum amount of air that you can forcibly breathe out after a normal breath. So you go to the doctor and they're, figuring out that end capacity. You're breathing normal. You're taking normal breath. You breathe out, and then you try to see how much more you can breathe out, breathe out, breathe out. That's what that is. Not really super important for us to know. A residual volume is the gas that remains in the lungs simply to keep the lungs open. So even when you breathe out, you're not completely getting all the oxygen out of your lungs. That would be horrible. You don't want our lungs to look like a balloon that is completely evacuated of air and it's all sucked together. Because what could happen if that was really happening with all of our tissues, if it was completely sucking together? They get stuck. It's not like they're just, like a latex balloon where it's all nice and loose. The tissues could actually stick together, and they do in some patients due to certain disease mechanisms, but we don't want that to ever occur. So we want to keep some air in the system so it's all ready to blow right back up again and expand without the tissues all sticking together. So we don't ever get rid of all of the air. Even if you're forcefully blowing every single little bit of air out of your chest that you can, you're not getting rid of everything that's in there. What would it take to get rid of all the air that's in your chest? It would either take a vacuum, or you've got to have, like a severe crush injury where you've got so much weight pushing down on you that it's literally pushing everything out of your chest. But you could not do that on your own without an external mechanism. Okay, we talked about dead air space. Minute volume is the amount of air that can move in and out of your lungs in 1 minute, subtracting that dead air space. So they would figure out how much volume is going in and out of your lungs, but then they would have to figure out how much dead air space you have and get rid of that out of that equation. All right, so characteristics of normal breathing. First of all, should it be real obvious? All of you are in this room are breathing right now. At least I hope you are. My lectures can make you stop. But I can't look at any one of you right now and obviously tell you're breathing. Because it's normal. It's subtle. It's not obvious. So there's a lot of patients that are the same way. We're going to obviously see them breathe. If you can obviously see someone breathing, you look at them and say, man, they are breathing. What does that mean to you? It could be respiratory distress, or it could just mean their body is needing a big demand of oxygen for whatever reason. So they're breathing heavy. Now, respiratory distress patient would be breathing heavy, right? And you'd see it. But what are some other reasons where somebody might be breathing more than normal, but it's not because they're in respiratory distress? Physical exertion. Okay, you're exercising. If any of one of you came back into this room right now after running around this building a few times, even though you're not in respiratory distress, I would be able to physically see you taking these deep breaths. Just kind of replenish your body. Okay, so that's normal. What's another patient that you might see where they're breathing harder than normal, but they're not it's not a respiratory problem? Okay, they might be trying to correct an acid-base imbalance. They're breathing heavy to blow off the acid, per se, like Kussmaul's respirations for a diabetic. They're deep breaths. They're a deep breath that you would easily be able to see, okay, because they're trying to blow off and correct that acid-base balance. Same thing would happen with somebody that's possibly has an infection or a fever or anything that is causing more demand on the body. They'll be breathing heavier to keep up with that oxygen demand for whatever the cause is. It doesn't necessarily mean it's respiratory in nature. But anytime you can see somebody breathing, unless just some people just breathe normal than others. That's just their normal. But if it's not their normal and you can physically see them breathing, that is not a normal respiration. And just start thinking, okay, well, what is causing them to breathe more than they normally do? And it may be somewhat normal, it may not. But when you breathe, it should be a regular pattern. We shouldn't be breathing and then stop and then breathing and then stop. It should be a normal pattern. Now, obviously, anytime we talk to somebody about their breathing, what happens? They'll change their breathing pattern. It's just some weird chemical process or mental thing with us. When they know we're looking at them breathing, they will change how they're breathing. So if you're ever trying to evaluate somebody breathing, don't tell them you're doing it because they will change it. So what's a good way to fake them out so that you don't realize you're looking at their breathing? And I'm not even just talking counting respirations. I'm like just evaluating breathing. Act like you're checking their pulse or act like you're checking something else. But while you're doing that, you're looking at their breathing. Otherwise, they really will change their breathing pattern on you. Okay, so breath sounds. What should they sound like when you listen to them? Clear. I mean, I almost want to say they shouldn't sound like anything, right? But that would trick you into saying they would be absent because we don't want to listen with a stethoscope and have zero sound. But they shouldn't sound like anything abnormal. It just should sound like air moving, okay? And it should be equal and the same on both sides of the lungs or the chest. How about the abdomen? Should it be moving or should it not be moving when you breathe? What is the main muscle that controls breathing? Diaphragm. What's your diaphragm going to make move? Your belly. So it's normal to see their belly move. Most people, I can't say it's most people because I don't really know this for a fact, but a lot of people, you don't really even see their chest move at all when they breathe. You mainly see their belly move. And it's not good or bad or either way, but some people are more belly breathers and some people are more chest breathers. It just depends on the person. But if you're trying to look at their breathing, sometimes don't look up here at their chest. Sorry for those who are listening to the mic as I'm tapping the mic. Don't look up at the chest. Sometimes look at their belly. And you can count their respirations by looking at their belly too. Okay. Now we're switching gears and we're talking about the circulatory system. Again, the respiratory system, man, that is a semester-long topic. The circulatory is a whole another semester-long topic. But we're just reaching just the surface of this, talking about the anatomy. So when we talk about the circulatory system and we're talking about the anatomy, what is the point of all of this together? Why do we need it? To move oxygen through what? Through the blood, okay? The oxygen is what we need to get there. The oxygen is going to attach to what? Red blood cells. The red blood cells are going to travel through the vascular system, right? But is there more in the vascular system than just blood cells? What else is in there? There's different types of blood cells, right? So we have the white blood cells, which are called what? Leukocytes. Okay, and what do they help with? Fighting off infection or any kind of foreign, invasion of any type. Okay, the red blood cells are the oxygen carriers. Okay, there's another one. What else? What is the other blood cell? Platelets. Okay, what do platelets do? They help the clot in case we have an issue where blood is going where it shouldn't be. It helps clot it up. But the platelets can also be a very negative thing as well in certain circumstances, because they will clot sometimes when we don't want a clot, and they'll create a clot where we don't need one. So especially specifically when we're talking about heart disease, a blood clot in a carotid artery is very bad. But that's what the platelets are for, is for clotting. Okay, and then there's just a fluid part of the blood, which just helps it all move through the blood vessels, because if it was nothing but cells, they wouldn't move anywhere, right? It needs that fluid to be able to flush through the system. Okay, is your circulatory system an open or a closed system? It's considered a closed system, even though parts of it diffuse in and out of the circulatory system, right? Because if it was 100% closed off and nothing can get in and out, it wouldn't do any good, because the carbon dioxide couldn't get out, the oxygen couldn't get in. So certain things can diffuse in and out of the system, but it's a closed system. If it wasn't a closed system, the blood would just diffuse everywhere, right? And it wouldn't work. So it has to be a closed system. All right, and obviously we were talking, a little bit ago about how the oxygen has to get out of the respiratory system and into the vascular system, and the carbon dioxide has to switch. Even though these are two independent systems, respiratory and cardiovascular, they work hand in hand and hand in hand in hand. Okay, they work very, very, very close together, and both of them can have big effects on the other system. All right, the heart. The heart is just a big muscle. Okay, but think of it not just as a muscle, but it's a pump. But not only is it one pump, it's what? Two pumps. Okay, so there's two pumps working together to pump the blood. But they pump the blood to very specific places, and they're different places. So when we talk about the heart itself, first of all, when we have venous blood coming into the heart from the body, what chamber is it dumping into? The right atrium. Okay, and what is feeding the right atrium? The superior and inferior vena cava. Okay, dumps into the right atrium. Does the right atrium, does it do anything other than just store blood? Doesn't do anything, right? It doesn't have anything to do with really the pumping of the blood. It's purely just bringing it in and storing it, okay? And then it's going to pump it where? Right ventricle, okay? Again, the right ventricle is just storing it temporarily, but it's a little bit bigger muscle down at the right ventricle because it has to pump it a little bit farther. Where's the right ventricle pumping blood to? It's pumping it into the pulmonary arteries. Well, that doesn't make sense. It's deoxygenated blood. Why is it in an artery? Because the common people think of veins and arteries as oxygenated and deoxygenated, but actually the technical term is they're going to or from the heart. That's why. It has nothing to do with whether there's oxygen in it or not. So since it's going away from the heart, it's an artery, even though it's deoxygenated. Okay, so we're pumping it out of the heart, through the pulmonary artery into the lungs. Okay, it's going to go through the whole circulatory system within the lungs, and then it's going to feed back into what? It's going to end up in the left atrium, but through what mechanism? What channel? Pulmonary vein this time. But this time it's oxygenated coming into that left atrium. And then it's going to sit and kind of sit there for half a heartbeat, and it's going to go down and sit into the left ventricle. Now, when you look at the heart's kind of long and odd shaped, right? And it's really muscly down at the bottom part of the heart. That huge, big muscly bottom part of the heart is pretty much all around the left ventricle. Because that's when it pumps, where it has to pump it through the whole rest of the body and then get back to the heart itself, all from that one heartbeat, all from the left ventricle. So the left ventricle is the workhorse of the heart. It's the biggest part of the heart, has the biggest need for oxygenation and everything. That's the workhorse of the heart. There are some factors that you have to think about when we talk about circulation, though, other than just the chambers and the valves and all. We didn't even talk about the valves, but all of that has to do with pressures. So there's two things that they talked about in your book were preload and afterload. Which one has to do with blood coming into the heart initially? Is that pre or afterload? That's the preload, okay? And it more has to do with volume. The more blood that can go into the heart, specifically that ends up in the right atrium, the more volume you have there, the more preload you're going to have. And it has to do with that Stirling's law and all the stretch. The farther it stretches, the more pressure you have pushing out. So the more volume you have, you stretch out the chamber of the heart. The more it stretches, the more elasticity there is to pull it back and push the blood out. So if you have just a little bit of volume, let's say the patient's bleeding out or something, and you don't, or they're severely dehydrated, they don't have the volume. If you don't have the volume, you're not going to get the stretch. If you don't have the stretch, you're not going to get the push. So the blood pressure is going to go down because of that stretch related to the volume. Okay. And the other pressure mechanism that affects the circulatory system is the afterload. This is where hypertension is a problem. Okay, afterload is the amount of pressure within the circulatory system already that the heart is having to push against. So the left ventricle, when it's trying to push blood out of the heart into the circulatory system, it's pushing against pressure that's already there. That built-up pressure that it's pushing against is that afterload that it's having to overcome. Now, people with severe hypertension have a chronic state of higher afterload that the heart is trying to work against. So if the heart is working harder with every beat through the afterload, what's it going to do? What does your muscle do when it needs to work harder? It's going to get bigger, right? So your heart will get bigger and bigger and bigger. The problem with hearts, it's not like a skeletal muscle. It can't get bigger and bigger and bigger and bigger and always be better. After a point, they get bigger and bigger and bigger, but then they don't work as well. And they actually get weaker and floppier and not as productive. So having hypermegaly, where your heart gets bigger and bigger and bigger, is not necessarily a good thing. It can be very, very negative as well. But that's basically the circulatory system in a nutshell. You have the heart muscle, okay? You've got all the chambers going through the heart, pushing the blood around, out of the heart through the arteries, back to the heart through the veins. And then you have the blood to go along with it, which has the fluid and all the we talked about the white blood cells, red blood cells, platelets. Okay, it's got the fluid part of the blood. Am I missing anything? We'll see. Since I wasn't using the slides, we'll see if I missed anything. Oh, we did not talk about the coronary arteries. And I'm going to skip over the valves because I'm just trying to waste time or save time. The coronary arteries do what? So they are actually, coronary arteries have zero to do with circulation, other than the fact that they make it so the heart itself works or doesn't work appropriately, because that's what feeds the heart muscle. So the heart muscle itself, when it's working, it does not get any of the oxygen or any of the blood that's flowing through it. None of that feeds the heart muscle. The heart muscle is fed from the coronary arteries. Well, where do the coronary arteries come from or break off of? They break off of the aorta. Okay, so the heart is pumping blood out of the left ventricle up into the aorta. The coronary arteries break off of that and then fill in the heart. With how it's designed, though, it's kind of it's opposite of what you would think with how the heart is fed. The coronary arteries are fed during diastole, not during systole. So during the contraction phase of the heart is not where the coronary arteries are fed. They're fed during the relaxation phase of the heart, is when the coronary arteries fill up. The only important note to do, or that has anything to do with that for us, is in CPR. So when you're doing CPR and you push down, that's the systolic part of the blood pressure, right? The blood going out of the heart. So that's not filling the coronary arteries. When you pull back up off the chest and diastole occurs, that's when the coronary arteries are going to fill. Well, what can we do that could prevent the coronary arteries from filling? Not recoil. That's why recoil and CPR is so important. If we're just keeping that positive pressure in the chest, the coronary arteries aren't refilling, which means, are you doing any good with your CPR whatsoever? getting a little bit of a workout, that's it. You're not doing anything for your patient. So make sure you recoil so those coronary arteries refill. Okay, so the coronary arteries, how many main branches are there for the coronary arteries? We have the right side, and then it breaks off into what? I'm going to make sure I'm thinking about this. Is right, and then you have the circumflex, the right, and the left. The left anterior descending is probably it's the biggest one because it feeds the left part of your heart. But any of those, depending which coronary artery, and they break off into a lot of little ones. There's not just like 3 arteries of your heart. There's lots and lots and lots and lots of arteries within your heart because they get smaller and smaller and smaller and smaller, like all the other blood vessels. You can have blockages in any of those. Now, what do those blockages come from? Sometimes it's a buildup of plaque that can take years and years and years and years and years to get bigger or to build up more and more and more and more, which makes the artery, the inside of the artery, get smaller and smaller and smaller and smaller as you get a bigger plaque buildup. Okay, or you can have a blood clot travel into one of those arteries. Now, what is going to determine where the blood clot stops? The size of the blood clot. The bigger the clot, the sooner it's going to stop, right? Because it's going to get to a blood vessel that it cannot pass through anymore. So the bigger the clot, the higher up in the vasculature of that coronary artery it's going to stop. The higher it stops, the more area it affects below it, downstream, right? So if you have a big, huge hose, you block it, that's feeding a lot of little hoses, all those little hoses are going to get obstructed. Where if it's a little teeny, 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 tiny blood clot or a piece of plaque that breaks off or something else, and it could travel way, 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 way deep into these little teeny, tiny blood vessels, it'll still block there. It can still cause problems, but to a much smaller area of the myocardium or the heart muscle. So do you think patients even ever notice the little teeny, 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 tiny blood clots they get? They won't even feel them. Typically, the little tiny ones, they don't have chest pain. It'll block a certain area. The body's pretty cool. It has the ability to, it's like, okay, well, this blood vessel's not working. We're not getting the blood around it. I'm going to build more blood vessels, and it will actually build blood vessels around little blockages. Patients never have any idea. It's the bigger ones that they have the chest pain and have the issues that we get called for. All right, but you're going to learn a lot more about that part of it in the cardiac lecture. So the other part of the heart now, or the circulatory system that we didn't talk about, we talked about all the major big parts of the heart and the circulatory system, but there's the electrical system too that makes the heart function like it should. Now, is the electrical system, is it fed by the brain or is it independent? Okay. It's a little bit of a trick question. It's actually both. Because does your brain have to constantly tell your heart to beat? Have any of you guys ever seen a heart that was recently dissected out of something that is completely detached from whatever it was in? Does it still beat? It still beats for a while. What's causing it to beat? Electrical impulses. Okay, so a heart can beat independently of the body or the brain for a period of time. Now, the heart, controls its own rate, but there's different factors that affect that as well, right? Now, can you sit here and think about it and make your heart beat faster? Not really. I mean, you could force your body to, you might be able to tighten up your muscles and make your muscles work or something, even though you're relaxing, that'll increase your heartbeat. But you can't really sit here and say, okay, heartbeat faster. Can you slow your heart rate down? You actually have a better ability to slow your heart rate down. But again, you're not sitting there telling your heart, go slower, and it goes slower. What are you doing to slow your heart rate down? You're relaxing. And the more you're relaxing, the less demand there is. So the less demand, your heart rate slows down. But you're really not regulating your heart per se, just by telling it to be faster or slower. But your body does that, independent of the heart itself, right? So the heart has its own pacemaker, but if it determines it needs to beat faster through it and through the brain and through all the receptors, sensing the carbon dioxide and oxygen levels, it will beat faster or slower as needed. So the electrical system starts with the SA node, the cyanotroph node. That's in the upper right-hand part of the heart. Okay, that is the pacemaker of the heart. It will create its own pacemaker for the heart. Just like we can put an external pacemaker on a patient that we regulate the rate, the SA node is doing the same thing for the heart. It is the pacemaker. The heart muscle is pretty amazing, though, the heart itself. If there is a problem with the sinoatrial node where it isn't regulating the heart rate like it should, or maybe it malfunctions, other part of the heart can then become the pacemaker. And it usually travels from the top to the bottom. So if you have a problem up high, somewhere still up on the top part of your chest, your heart will take over and be the pacemaker. The important thing for you guys to know is just, though, that different part of your hearts can become the pacemaker. It's not always the SA node, but it should be if it's working properly. But as you get lower and lower and lower and lower and lower in the heart, if something else becomes the pacemaker, the heart rate drops a lot. The lower it is in the heart that's creating the electrical impulse, the slower the impulse becomes. So with that in mind, what do you think the impulse is for the sinoatrial node, since that's a normal pacemaker? What's your normal heart rate? 60 to 80. So that's, the normal range for that pacemaker of the heart. And then, as we have patients, you go on a patient that's bradycardic, maybe their heart rate's in the 40s for whatever reason. Do you think it's coming from the SA node? Maybe, maybe not. Depends on the particular pathophysiology that's causing it to be slow. But if it's due to a heart block in the electrical system, then it's not coming from the SA node. It's coming from somewhere lower, more like maybe the AV node. If you're talking clear down to the Purkinje fibers, the bottom part of your heart, if that's producing your electrical impulse, you're going to be down really slow. 20s maybe, and it's not going to be very effective. But I'm not going to get specifically into all the ranges for all the different parts of the heart right now. Just know the electrical conduction, as it travels down the pathway, as the current starts at the SA node, travels down that pathway through the heart, it's triggering those muscles to contract. So that's how it gets it to contract in an organized fashion, by traveling down through those pathways, and the muscles contract as it goes. Because you don't really want all of your heart just to contract all at once. It wouldn't work as effectively. So it has to be kind of an organized pattern to get the two separate pumps to pump in relation to one another through those electrical pathways. Questions on just the basics of how that works? Kind of makes sense? And we talked about that. So I know a little while ago I talked briefly about systole and diastole. Systole is when the heart's pumping, forcefully contracting. Diastole is when it's relaxing. We talked about.
I'm sure this will be brought up down the road, but what's the importance of the pulse pressure?
For what we do, not much. There's not a single time I can think of where I really look at the pulse pressure and have that effect one way or the other, anything I do. Yeah. I'm going to breeze over a lot of this because the stuff I was just talking about when we were talking. Okay, I did not specifically talk about this when we talked about the blood vessels. There are different layers to the blood vessel. Again, I don't know how important this is that we know it for this level of education, but just so you know, there's the tunica intima, which is the inner lining of the blood vessel. It's all smooth. The blood will easily pass through it. The tunica media, which is the middle, and the tunica adventia, which is the outside of the blood vessel. That's as much as you need to know about that. A lot of this now was just talking about how the blood vessels go to different parts of the body and just terms for that. I'm not going to sit here and waste your time by reading all the terms off to you. Okay, so the aorta, I will briefly talk about that. I'm sure you guys are well aware of this already, but so you have your thoracic aorta and your abdominal aorta. Is it the same blood vessel? Yeah, it's just where it is in the body, right? So the thoracic aorta is where it breaks off from the heart, goes up, the coronary arteries come off it spins around. You've got the carotid arteries that break off of it. There are other arteries break off as well, but it's going to travel down through the diaphragm and then into the belly. Just know that it is throughout your entire chest and abdomen that you have that aorta. And know that if there's a problem with the aorta, it's a huge, huge, huge deal for the patient because of what? The amount of volume that blood that goes through that aorta. So if they have a dissecting aneurysm or something where the blood isn't flowing where it should, just know that there's a massive amount of blood where it could be an issue. And it's also in your belly, not just in your chest. Okay, the composition of blood. Most of it is just fluid. So 55% fluid, just a watery substance. And then 45% of it are the cells within that fluid, which we already talked about. All right, one thing just to be aware of with the red blood cells, they do have those antigens on their surface. They're looking or feeling for things within the blood, and have a factor in immunity and allergic reactions and that kind of stuff. They kind of have a factor in that. And they also have, this is a specific reason why people can only accept or donate certain blood types because of these little antigens. If you have two different antigens that don't correlate together, the body will fight it off as a foreign subject, and the leukocytes will kill off the blood cells. So that's why if you get a blood transfusion from somebody that has a different makeup of their blood that's not compatible with yours, it will actually harm you, not help you. And your body will have to fight off and kill off all that blood that they're giving you. And sometimes if you're getting blood, you're already pretty sick. And oftentimes if that happens, you're sick enough you can't fight it off. So it used to be, a long time ago when somebody would need a blood transfusion, they'd actually sit somebody right next to you, stick a needle in there with a tube and a needle in you, and the blood was going right from one to the other. Well, a lot of people died from that due to the antigens related to the blood transfusion with all that. Now, all the blood banks and stuff, they're the ones that are testing your blood, making sure that you can get the blood that's being given to you. And it has more, blood typing is important. We do the blood types, but there's RH factors and a lot of other stuff that go into blood transfusions for certain populations that they have to know. So just know that all blood's not created equal, and not everybody is compatible with everybody else. How much blood does an average adult male have? Do you guys know? 5 liters of blood. Okay, the lymph system. So we talked about the circulatory system, and I skipped over some of the stuff that's really redundant. The lymph system. What are we moving around in the lymph system? Are you moving? Does it have anything to do with the circulatory system at all? Nope. Whole different system. There's still tubes that can move stuff around, kind of like blood vessels, but they're lymphatic vessels. They're not blood vessels. Okay, and they can move fluid as well, but it's completely different than the circulatory system. And it's done passively, not actively. So it's not done through a big pump like your heart moving it. It's more of a passive process. But foreign materials are moved through this system to be filtered out and taken care of in your body. It's basically just part of the filtration system of your body to get rid of the toxins and bad stuff out of your body. And just like blood vessels, lymphatic vessels are all over your body because everywhere has to get rid of that material that's being broken down and needs to be gotten rid of. All right, the central nervous system. When we talk about the central nervous system, we're basically talking about 3 different things. And what is that? Your brain, spinal cord, and the nerves that attach to it. Okay? But the central nervous system is both basically your brain and spinal cord. But the nervous system is all of them. So when you talk about the brain itself, we have the cerebrum, the cerebellum, the brainstem, which is the most critical for life. Brainstem. And that's why it is the most protected in the middle of your brain, and it controls all the real life-threatening stuff. The cerebrum is the biggest portion of your brain. It is composed of the 4 lobes, the frontal, parietal, temporal, and occipital. And each of those have very specific things that they do and control. The cerebellum coordinates various activities in the body. The brainstem does the central nervous system communication. I'm going to somewhat breeze over this because a lot of it is just purely memorization. Okay, so we have a central nervous system, which was what? Brain and brainstem. And then I said there was also the nerves that go into the rest of your body, which connect to the central nervous system. That is your peripheral nervous system. Okay? Is there any area of your body that does not have nerves in it? There's not. Everywhere has nerves to control all the body functions with all other body functions in your brain. So everywhere has different nerves. They're totally different type of nerves, whether it's, sensory nerves or, nerves that are regulating on the other mechanisms, or if it's just your motor nerves from helping you move your body around. But everywhere has nerves in it. I talked earlier about the dermatomes. That's what this is, where a particular nerve tract, they can look at where it breaks off from the spinal column and that nerve tract, and specific what body areas it affects or controls. You do not have to memorize all the dermatomes. Okay, again, that was about the briefest explanation of the nervous system there could be, because it is a horribly complex system. But today's just an intro into the anatomy. Okay, the eye. The eyeball is called the globe. The conjunctiva is the conjunctiva covers the inner surface of the eyelids and the exposed surface of the eye itself. And behind that's the iris and the lens. Okay. What is the point of the lens? Does it have any actual function itself? The lens is just a protective covering, right? And what is the opening in the eye called? The actual circle. It's a pupil, okay? And then what controls focusing and light and all of that? Just the retina and everything moving and opening up that pupil larger or smaller to let more light in or get more light or keep light from coming in. The lens will shape or can change shape somewhat to help focus, even though it's mostly there for protection. The lens itself also can change a little bit of shape to help focus things in and out. When we talk about our world and EMS, is there a lot that we need to worry about with the eyes? Not really. Do we? Other than just keeping them safe. If we have an eye injury, what are you typically doing with the eye? Just covering it and trying to keep them from moving it the best they can, whether that's controlling the other eye too so they don't move together. But we don't really do a whole lot with the eye. It's mostly just get them into a doctor who can actually care for that eye injury or infection or whatever it is. All right, the integumentary system is the largest organ in the body, and that is what? All your skin, okay? What is the number one point of your skin? Basically, it's a barrier of protection. It's two things. It's to help hold everything inside of your body from going out, but it's basically there as protection, okay? And it also helps control temperature. Okay, digestive system. What is the point of this whole system? Isn't it nice how we can treat a whole body system in with 2 slides? It's ridiculous. Digesting is a way to get food from the outside into your body, get what you need out of it, the nutrients and stuff that you need from that food digested and into the body areas it needs to go, and the waste excreted. And that is basically your digestive system in a nutshell. Now, there's lots of different components of it. We're talking about the mastication process where your teeth are chewing up the food, or are we talking about just the digestive enzymes that are helping digestive food itself? Are we talking about our large and small intestines, where the food's actually going through that portion of the body, and the different material are being pulled out? That whole system all has to work together. But basically, in a nutshell, it's getting food into the body, broken down into usable sources, and all the waste from that excreted back out. When we're talking about breaking down food, though, what level does it get broken down to? So what do your cells need to live? Glucose. Where does the glucose come from? And basically, where does it start? As food. So eventually, all the food that we utilize gets broken down into cellular components. Into glucose. Same thing with the fluid. We drink all kinds of fluid during different mechanisms. But really, out of all that fluid we drink, what do we need? H2O. It all has to get broken down into water somehow. Like all of you guys have different drinks in front of you. They all have different flavorings and different components in them. But really, when we talk about the fluid part, it has to get broken down into just the water molecule for your body to be able to use that water. So it all gets broken down to the smallest elements it can be. Okay, the abdomen. We kind of break that into 4 quadrants. It's not that there's any physical separations in those 4 quadrants. If you were to dissect somebody's belly, is there going to be nice separation of all 4 quadrants? No. That's just for us to be able to easily communicate with somebody else where the structure is that we're talking about. But we do have the 4 quadrants in there. What is the major stuff that's in your belly? Is it what body system is mostly in your belly? It's the one we just talked about, right? The digestive system, your stomach, your small intestines, large intestines. There are other organs in there though, but those are the one that take up the most space. So some of the other stuff that's in the abdominal region, although some of it's more posterior and some of it's more in the middle, but we have your liver, kidneys, pancreas. So where's the liver at? Right or left? Right. Is it high or low? Up high. Oftentimes, even a lot of the liver will almost even poke up under the rib cage, but it's really up high. Can you feel the liver when you palpate somebody? Normally, no. At times, you can. If you can feel the liver, that's a bad thing because the liver is really enlarged, usually due to backup of blood into it, but it can get really enlarged. So if you feel it, that's a bad thing. What about the liver do we worry about with trauma? Bleeding. It's very vascular, bleeds a lot. Okay. All right. Where are your kidneys? Okay, more in your more posterior on either side. Okay, what are the kidneys for? Filtration. Okay, where is your pancreas at? Pancreas is it is a lot in the middle, okay? But then it also kind of goes over to the left side of the patient a little bit. But it's really the biggest part of the pancreas is more in the actual central part of their chest. Or not their chest, but their belly. What is is the pancreas highly vascular or not? It is. The pancreas will bleed quite a bit too. All right. Then the other thing that's we already talked about the digestive, so we're not going to talk about all that. The other things that are in the abdominal region and below that are all the reproductive organs. All right. We are going to skip over that. All right, we're going to skip up to this because I talked about most of the other stuff. Oops, did I go too far? All right, endocrine system. What does the endocrine system do? Messages via what? Is it through neurotracts? Nope, it's not electrical symbols, it's chemical. Okay, and it's done through hormones. So the endocrine system is your hormone system, where it produces all of your hormones and it affects other body functions through the release of specific hormones. There's different areas that different hormones are produced, and different body areas utilize different hormones. But just know, in a nutshell, the endocrine system is your hormone system. This doesn't get into specifically what hormones do what, but just know that the endocrine system is a hormone system. A couple of the ones we'll talk about: the thyroid gland secretes calcitonin. The parathyroid glands produce and secrete the parathyroid hormones. And there was one thing I wanted to talk about with those, I think. Scroll down here a little bit. Oh, maybe not. Never mind. Are you guys getting as blurry-eyed as I am at this point? Okay, we talked about the pancreas earlier. What did we talk about the pancreas in conjunction with? Cancer, okay? It's a really bad one for cancer. But what is the pancreas is part of the endocrine system, okay? It also helps with the digestive system. And what do you think it does to do that? What's it produce? Yep, it produces different enzymes to help with digestion. But it also is where we secrete glucagon from, and then also the beta cells within the pancreas in that system secrete the insulin. So both of those have a lot to do with regulating that whole part of our body. But when we're talking about people with diabetes, this is where their problem is. It's a pancreatic issue. Either it's not producing insulin like it should, or not enough insulin, but this is where the issue is. And it's all part of the endocrine system. Oh. Okay, and then some other glands that are part of the endocrine system are the adrenal glands. These are on top of the kidneys. They produce epinephrine and norepinephrine. So what does epinephrine do to your body? If your body or your adrenal glands were to release epinephrine into your bloodstream or into your body, what's the reaction it's going to have in the body? Lots of them, but what are the main ones you're going to see? It's your fight or flight. Your heart rate's going to go up. Your heart's going to start beating harder and faster. Your pupils will dilate. There's a lot of other things that happen, but it's that whole fight or flight mechanism. All right, the other part of the reproductive system, the endocrine system, has to do with the reproductive hormones. Okay, switching gears now from the reproductive, we're almost done, guys. The urinary system. What is the main couple points, or what is the main couple functions of our urinary system? Why is it important? Okay, it excretes waste. Okay, what does it help? Does it help at all with fluid balance? How can it affect fluid balance? Right. Your kidneys determine whether it's going to take the fluid and dump it out through the urinary system, and along with the other excrements in the urine, or if it's going to dump out the waste products but hold the fluid products back. So it can filter out the waste and still hold on to some of the fluid and give the fluid back into the body. Okay? And it's hormones that will help determine that, whether it's different hormones as well as sensing the amount of fluid in or out of the cells is going to determine that. Now, can we affect that with medication? Okay. So some people like it. I keep going back to the congestive heart failure one for some reason today. So somebody with congestive heart failure, what type of medication do they put them on? Okay, what does Lasix do? It makes them pee off the fluid. So basically what it's doing, it's affecting the renal system, and it's having them excrete more fluid and hold on to less fluid. So we are changing the chemical balance of that system through medicine to help it push out more fluid instead of holding it. So we can affect it through medicine, but your kidneys are doing more than just filtering. They're also have a major role in fluid balance, whether you have enough or not enough fluid in your body through that mechanism. Okay, so this, again, is the reproductive system. So male reproductive system and organs. I don't think there's anything I need to talk about with this other than the fact that you guys know it exists and affects reproduction, obviously, through hormones and through everything else. All right. So you know what this slide is? It's really exciting. It's the very last one. So basically today, we started talking about the cells, right? What's important about the cellular mechanism at that level? Just knowing that each cell is a living thing all by itself. Okay? It needs oxygen, it needs glucose, it needs to be able to work. It needs to be able to work and get rid of its, the bad stuff out of the cell. Then all the cells work together. Okay? Cells that work together that are all similar form what? Tissues. Tissues that are all similar and have a common use, form organs. Organs that work together in a certain thing create a what? Organ system. How many organ systems are in the body? 12. And after this really exciting lecture, you guys are well versed in all 12 of those and exactly how they work. You guys are practically doctors after this. Okay. So again, this was just a really, 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 really brief overview of all 12 of those. If you have any questions, let me know. We're going to talk about all of these in more in depth now as we get into this course. These first couple classes, I'll be honest with you, they're some of the harder ones to sit through and absorb because they're so broad. But as this course goes, we're going to narrow that down and narrow it down and narrow it down. And it'll be more specific to each specific area and how we can affect or help patients that have problems with all these different areas. Okay. All right. So what do you guys need to do now as far as just the course in general? What's the next step for you after today? I need those packets filled out for your clinical health internship. Again, if you are not going to do an internship at Kootenai Health, you don't need it. This is only for people that are going to do the internships. I need those packets as soon as I can. The other thing I need from you guys before anybody leaves, you cannot leave this classroom until I get a picture of you. Okay? So we're going to do that before we go. If anybody off-site can please give me a picture. Shoulders and head with a dark background. That'd be great. Otherwise, I'll have to catch up with you and get a picture. Your test from today's class will open at noon. I have it preset in the computer. You can't take it until noon, so we're out a little bit early, but you're going to be stuck. You can't take it until noon. Are we that close? You have until the end of the class to take that test, but please do not wait to take all your tests at the end. Please take your tests as we go because you will do way better on them. Yes, sir.
Paperwork, what do you want in their school?
Just put CDA fire or KCFR. I don't care which. Both of us have contracts with the hospital. All right, thank y'all. Did you stop the recording, Pete?
While you're waiting for pictures, does anybody else want a cup of coffee?
I don't know how to stop the recording. I'm going to go take some photos.
You had a paperwork you handed out in the beginning of the class?
Just
Beside that packet?